Yes, we can hear you.
Okay. Assalamu alaikum everyone. My name is Mohammed Alfuwais. I'm a third-year medical student, and inshallah today I will be going over the RAD post-midterm lectures mostly. Now, me and Tariq basically pretty much separated them into halves. He covered a lot of pre-midterm yesterday, and he also covered a lot of the basics of post-midterm. Yani, for example, he covered the MRI basics, the physics behind MRI, nuclear medicine. So today I'll be explaining all the clinical aspects of all of radiology. So this is majority of post-midterm pretty much. So I'll be going over 6 lectures, inshallah. A lot of it I'll be going fast in because you guys already did a lot of it in pre-midterm. For example, I think this lecture specifically, CT, you guys took pre-midterm. But so I'll go fast in it and I'll explain the major concepts. And for the rest of them, I'll give you key points to focus on that usually might come in the exam. So inshallah, this helps you guys through this entire, studying for the last exam in second year, and you get through, inshallah, with flying colors, inshallah. So to start, I'm going to be going over the clinical applications of CT with the clinical correlations. Before that, since I need to quickly review, now for the Hounsfield scale, obviously, you know that CT is based on attenuation. So what does that mean is basically if any structure is more calcified and uptakes more radiation, this means that it's higher attenuation. And in CT, the key term that we use is density, okay? So it's higher density or lower density. Now the middle point, which has a Hounsfield unit scale of 0, is water. Fat is going to be hypodense than water. So it's going to be less than water. And the most hypodense thing that you have is air. Air will be pitch black pretty much. Then you have cortical bone because it's calcified. It will basically uptake more of the radiation. So it will be higher attenuation and more dense. Another term you can use is radiolucent if it's more darker, or radio-opaque if it's more brighter, but it's not commonly used. It's not commonly used as, for example, density, for example. But when do we use CT scans? CT scans are widely used for a bunch of different things. A lot of different indications for CT scans that we use. It's one of the easiest modalities to use. It's very quick. A lot of hospitals have this. And one of the key points that we need to remember is traumatic cases. So anyone who comes in, for example, with car accident, car crash, the first thing you want to do is do, for example, a full body CT, or for example, CT of the chest, abdomen, and pelvis. That's, for example, the key modalities to use, or the key modality to use in that case is CT. Another thing, which is anything that is acute, very fast, you need to get the diagnosis fast so you can treat the patient fast, use CT scans. So for example, in CNS conditions, but specifically acute, for example, strokes. For acute stroke, you need to use CT. Then you can treat the patient afterwards. MRI can be used for the brain, but for other indications. For stroke, the first thing you do, and for every question you get, what's the first thing you do for stroke? CT, okay? So then other respiratory conditions or chest conditions, for example, COPD and lung cancers as well, and some gastrointestinal lesions. So for example, appendicitis, bowel ischemia, and some cancers as well. You use CT to visualize the GI system way better. And then, for example, as I said, trauma. Now, this is the normal brain CT. To go very fast, the things that you need to look into in the normal brain CT are just the normal structures. You can see the gray matter and the white matter, for example. This is the white matter, and this is the gray matter. And you need to see the ventricles. Once you see the ventricles, they're very thin, small in a younger patient, in elderly patients, and such as in this one, it's much bigger. So this is what you look out for in a brain CT. Okay, so again, you look into the gray matter on the outside and white matter. You need to be able to distinct between these two structures because, for example, strokes, you have different strokes that will present differently on CT. You have, for example, one that will cause cytotoxic edema and one that will cause vasogenic edema. Okay, and we'll get to it later, inshallah. Then you look into the midline, for example, if it's shifted or not. You look if there's any hemorrhage or something like here, but there's nothing, obviously. And you look into the ventricles, as I said, if there's any hyperdensity or any density at all in this area. You might think there's blood in the, for example, the CSF. You might think of specific causes of hemorrhages, as we'll get to. And this is in an elderly patient. As I said, the ventricles are much more wider in elderly, and you can see some like atrophy of the gyri and the sulci. You can see it's much smaller. The brain itself is much smaller than this. Okay, so that's pretty much the difference in younger and older brains. Now, the first thing, as I said, is you look into the ventricles and the CSF in general. Here you can see is that the CSF, which should be over here, and CSF should be dark in color, is now hyperdense, okay, or more radiopaque. This means that there is blood in the CSF. And specifically, this is in the subarachnoid space. So what do we call this? Subarachnoid hemorrhage. And it's very easy to tell. You can see this over here and over here. And you can see some bleeding over here. This all that I'm highlighting is basically where you have the distribution of the subarachnoid hemorrhage. Okay, and it's typically like, I don't know what they call it, spider shaped or whatever, but pretty much it just follows the subarachnoid space. Okay, the common presentation, you guys took neuro, probably should already know this. Young patient who just had a severe acute onset headache, the thunderclap headache, whatever. Okay, so that's how you can tell subarachnoid hemorrhage on CT. The next thing, which is super important for your exam purpose, is cytotoxic versus vasogenic edema. Now, this is a picture from Google pretty much, just to explain the purpose of this. So I'm going to explain vasogenic at first. In vasogenic, you can see here that you have edema, you have a swelling in the brain, you have a collection of fluid in the brain. However, you can tell that there's a difference, clear distinction between this and this. This is the gray matter, and this is the white matter. White matter is more hypodense. Why is white matter more hypodense? If someone can answer that question. Exactly, because it has more fat. More fat will make it more hypodense. Excellent. Okay, so you have more fat, so it's more hypodense. So when you see vasogenic edema, there's a clear distinction between the gray matter and white matter. You can tell the difference between them. However, when it's cytotoxic edema, you cannot tell the difference between the two. You can clearly tell, like, you can't tell where the gray matter is over here or the white matter. There's no difference here. So this is cytotoxic edema. Cytotoxic edema happens specifically in ischemic stroke. Okay, so cytotoxic ischemic stroke or in infarction. Okay, just ischemia. Okay, because the cells are dying in this case. So when you have ischemic stroke, everything, for example, if this is where you have the middle cerebral artery, everything beyond this point will not receive blood supply. So everything will die. So that's the case of that. However, here you will have, for example, a hemorrhage where it will, like an artery, for example, will start bleeding over here. This area will still get perfused, but it will still be ischemic. But however, there's still blood. Okay, and it will accumulate the blood in one of the spaces. Hence why it only, for example, happens in the white matter. And that's why you can clearly tell the difference between the gray and white matter. Okay. Now, this is important. Why? Because in vasogenic edema, you have other causes. You have, for example, a cancer, a tumor. A tumor might cause surrounding the tumor, you have vasogenic edema. So you have to just tell the difference between cytotoxic and vasogenic. Vasogenic has other causes, such as tumors or abscesses. Okay, so that's that. This is just exactly from your slides. Again, this is cytotoxic edema because you cannot tell the difference between the gray matter and the white matter. It's completely mixed up. So you have ischemic stroke here. Here you have hemorrhagic or vasogenic. It could be also a tumor, but this one is hemorrhagic. You can tell over here, this is the gray matter. You can clearly tell it over here. Okay, this over here, but it's because it's swelling and pushing outwards. It might not be fully visible, but you can clearly tell a demarcation here. Okay. So this is gray matter over here, and this is white matter. Okay, but obviously there is edema. Okay, this is vasogenic edema, and that's pretty much that for strokes. Now for brain metastasis. For brain metastasis, you use CT. Now look over here. This is the same exact thing of vasogenic edema. You can clearly tell this is the gray matter. And you have some parts such as over here, maybe this is the part of the white matter and all of this over here. Okay, this is all edema. This thing over here is a tumor, but you need to do CT with contrast in cases of tumors to be able to visualize the tumor better. Now, what happens when you give CT contrast? The contrast will basically be uptaken by the tumor itself because the tumor is vascularized. It needs its own blood supply, and its vascularization is much more than normal tissue. So what happens when you give contrast is this tumor will basically take it up all of the contrast, and it will keep the contrast for a bit. So when you see this, for example, it basically uptook all the contrast. So you'll be able to visualize the tumor very clearly over here. Okay, so this is brain metastasis because usually tumors in the brain are usually metastasized tumors. Okay, so that's pretty much how you can tell that. Was all of that clear so far? Perfect. Okay, another important concept in CT is that you have different windows. Now you have, for example, this window over here that we use for the brain. It's most likely soft tissue window or something like brain window or whatever, CNS window, whatever they want to call it. But basically the point is that this is targeting the attenuation of the brain, okay, similar structures of the brain. When you look at the bone, the skull, it's very hyperdense. You can't tell the details of the bone. Why is that? Because you have to do a bone window to be able to tell the details of the bone. When you do a bone window, such as this one, you can clearly tell the small little details of the bone itself. You can tell that, okay, there's like a cavity here. For example, there's a suture line over here. You won't be able to tell that over here. But here you can. In bone window, you can tell the small little details of the bone, such as bone fractures, which is here in the skull. Okay, so skull fractures, you can tell it, but you have to use bone window. And just keep in mind the concepts of window where you can basically change the attenuation based on the structure you want to look at. And this is important, especially in the chest, because you can change it from long window to soft tissue window, and you can see different structures from that, and we'll get to it inshallah soon. Now, this one. If a patient had, for example, trauma, and then 2 hours later had a severe, for example, neurological deficits, had signs of a stroke, and then you do a CT and you see this. When you see this, this is a epidural hemorrhage, okay, or epidural hematoma, which is basically it's bleeding below the dura. Now here, because it's bleeding there, it cannot cross the suture lines. So it starts to compress onto the brain, and it will basically cause a mass effect, where it will push the midline towards the other side of the hemisphere. What you need to know for this, just as a concept, is that what is this? Like they'll give you a picture of this. What is this? Epidural hematoma or epidural hemorrhage, lentiform shaped, and this. Like that's these facts I have in this on the slide. There's nothing else. Just be able to recognize what this is. Okay, and it's pretty simple, inshallah. Now we start going downwards to the vertebral fractures. Typically, fractures of bone, you need to differentiate it if it's vertebral fracture versus if it's extremities fracture. Because extremities fracture, the modality used is different than vertebral fractures at all. It's not the same. So in extremities, for example, if someone fell on his arm and had a radial fracture, the first modality you use is X-ray. Okay, if someone fractured his femur or fractured his tibia, the first modality you use is X-ray. In spinal cord, in vertebral cord, you need to use the CT. Okay, you need to use CT, and this helps you visualize the vertebral bones basically. So here, this is normal. There's nothing like no fractures to see here. You need to just recognize that there is a fracture here. Okay, that is the fracture right there. Okay, so that's the only basic thing that you need to recognize from this slide pretty much, is that vertebral fractures, the thing that you need to know, the modality you use is CT. And for extremities fracture, the modality you use is X-ray. Okay, so that's basically the modalities that you need to use. So that's that. Now we go to the chest images. And in the chest images, again, to review the concept of window, this over here is soft tissue window. The reason why this is soft tissue is you can clearly visualize the great vessels, for example. If you give contrast, you can see it way better. You can see this is, for example, the pulmonary artery and the bifurcation, the ascending aorta, descending aorta, and then you can see here all the muscles in the back and then some of the fat over here. You can't tell it perfectly, but you can still see it. So this is soft tissue window. Here, this one over here, it's the lung window. In the lung window, you can clearly tell it's just like much more easy to tell. For example, the different vessels going into the lungs. If you can see, for example, some of the airways with the level is different. But anyways, you can see the lung way easier. The reason why you need the lung window is, for example, if you want to tell if the patient had COPD, if the patient had interstitial lung fibrosis or interstitial lung diseases, or interstitial pulmonary fibrosis. You need to tell those diseases by looking into a lung window. At the same time, you need to see it if you're trying to visualize a mass, a cancer. Okay, so you need to use lung window in this case. For soft tissue, especially if you give a type of contrast, for example, you can tell the great vessels way better in this case, and we'll get to an indication for that, which is this. So using soft tissue window over here, you have a case of, let's just say, a woman who's postmenopausal, let's just say, and she just came from a 12-hour flight with an acute onset of shortness of breath. What do you think she has? It's in the slide. Yeah. She has pulmonary embolism. Now, what modality can you use for pulmonary embolism? Good. Yes. CT with contrast. Excellent. So yes, you can use CT with contrast, and the window in this case is soft tissue CT, as you mentioned. But here you can see clearly this, what's it called? The great vessels. This is the normal one, and this is the one with the pulmonary embolism. This thing right here is the pulmonary embolism, is the emboli. This is what we call a saddle emboli. Okay, so basically it's blocking both entries of the pulmonary artery that will supply the lungs, that will perfuse the lungs. And then for this case, if you cannot see the emboli from using a CT with contrast, there are other modalities you can use, and I'll get to that way later, okay, for pulmonary embolism. But just know for CT with contrast, you can visualize the saddle emboli. They'll give you basically a case, they'll put this picture and ask you what this is. That's pretty much how they might ask you this question. Now this is again soft tissue window. The reason is the lungs are completely black. You can't tell anything, and you can see the heart pretty well. Now this over here is a pleural effusion. You can see a bit of it also on the other side, but on this side you can clearly tell it's a massive pleural effusion. Okay, the reason why it's pleural effusion, there's liquid here. Okay, so it's clear. The lungs are black, it's air. This one is a bit more hyperdense than this, okay? So, yeah, that's it. This is just a pleural effusion. The pleura in this case is normal. How do you know if the pleura is abnormal in this case? Is you look at the thickness of this pleura, and this will basically show you the difference. This pleura is thickened. So this is what we call pleural inflammation or pleuritis, okay? So this is thickening of the pleura right here. It's very thickened. You have some pleural effusion over here, and you have some sort of pneumonia or lung infection going on at the same time. Just recognize this is just pleural effusion. This has more to it. This has pleural thickening, pleural infection, for example, or inflammation, and lung inflammation itself, and also pleural effusion. So that's just she wants you just to know the difference between the two pictures. That's it. Now, if you have a patient who has weight loss and has been coughing for months, and let's just say has blood in their cough, okay, in their sputum, hemoptysis, what's the first modality used? Excellent, good. So the first modality used when you're suspecting a lung mass or lung cancer in this case is X-ray. Once you see the X-ray, you can tell that there is a mass right here. However, what's the limitation over here is that you can't tell where the mass is. You can tell that it's in this left lung. However, you can't tell if it's in the anterior part of the lung or the posterior, or if it's even in the lung, okay? It might be somewhere else. So to best visualize where the lung mass is, you do a CT, okay? And this is in what window? Lung window, excellent, good. So you see over here, this is the mass over here, and this is clearly a lung tumor, lung cancer, most likely. We're going to have to do biopsy, and I'll explain how to do that later, inshallah. So now, the next thing is COPD. COPD, or interstitial fibrosis, interstitial lung disease, multiple names for this. The best modality to use is going to be chest CT, okay? So you can see why is because once you do a lung window, in this case, you can clearly tell the parenchyma of the lungs. Once you can tell the parenchyma of the lungs, you can tell if it's thickened, if there's any, for example, cystic dilation, some, fancy terms that they use, whatever. Basically, all I'm trying to tell you guys is the lung fibrosis, COPD, is best visualized by CT because you could do a lung window and you can look at the lung parenchyma itself. You can see if it's fibrosed, okay? So remember, COPD, interstitial lung disease, the best modality is CT, okay? Now, a lot of the abdominal organs use CT for, a lot of it. There are limitations. There are instances where you have to use something else. And those limitations are, for example, if it's a child, if it's a pregnant woman, because you can't expose them to radiation. And because of that, there are certain limitations for certain points that you need to diagnose, or certain diseases that you need to diagnose. However, in most cases, you do CT, okay? So one important thing that you can tell with CT will be liver metastasis. With liver metastasis, you can do a CT. Now, can someone tell me the difference between these two CTs? Contrast, good. And how can you tell this one had contrast? This one. Aorta, good, perfect. So the aorta is white in this case. So once you see the aorta white, you use contrast. The reason why we gave contrast is the exact same reason I explained it in the brain metastasis, is that the cancer will uptake the contrast. So you can see here, these are 2 points, 2 lesions in the liver, most likely going to be a metastasized tumor to the liver, okay, from the GI somewhere. Okay, so since it's multiple cancers, if it's one singular cancer, this is from the liver itself. So that's pretty much that. Like, you can visualize metastasis to the liver by using, for example, ACT, and you can use contrast to better visualize it. Here, you can't tell anything. Everything is isodense. It's the same density. So that's that. Now, for the adrenal glands. For the adrenal glands, you use CT, same thing. Now, in this case, this is just a normal adrenal gland. It's a Y-shaped structure, same thing on this side. Nothing like abnormal to see here, and then here it is over here, and this is like a very slender shape, like basically a line. Okay, it's very thin. That's basically the adrenal gland. Now, here is this. This is again the normal adrenal gland. Here's an adrenal mass. Now, the adrenal masses are typically benign, and they're typically filled with fat. Okay, so on CT, if you see that if there's a big structure that's more hypodense and it's in the location of the adrenal gland, think it's an adrenal adenoma, for example. So this is, for example, an adrenal mass that is hypodense. The reason is there's fat, okay? The adrenal gland is filled with fat because all the steroid hormones will come from there. So that's why it's very fatty, okay? So that's pretty much the concept behind why it's hypodense compared to everything else. Is that clear for everyone? Good. So now kidneys. Kidneys is very interesting in terms of imaging because there's so many things you can do for kidneys. But now look, if I give you this case, I want you guys to tell me what modality you use. This is very important that you recognize this. If a 20-year-old male presents to you with acute renal colic, okay, what modality do you use? With or without contrast? Perfect. Someone said ultrasound. Now, and no, it's not with, it's with, yes, okay. Never mind, I read it wrong. It's without contrast, you're right. Yes, someone said it's ultrasound. Now, look, kidney stones is the one thing that you, exactly, it's for chronic repetitive for ultrasound. However, kidney stones typically, there are a lot of different types of kidney stones. And this is something you'll take next year. But just for now, your concept, there's a lot of different types of kidney stones. Most of them can't be detected on X-ray, and most of them will not be in the kidneys. Okay, so ultrasound will only show you hydronephrosis if this is later on. However, in acute renal colic, because it's in the ureter, for example, it will cause pain. It will cause the renal colic pain. Okay, so because of this, if you do ultrasound, you won't see anything at all since it's in the ureter. So because of this, you need to use CT without contrast, because contrast will basically wash everything away and will cause everything to appear hyperdense. Okay, so I hope that's clear in terms of what to use now. There are limitations. For example, if someone has repetitive renal colic or pain, for example, and then you check for the kidneys and you see hydronephrosis, or you see, for example, a mass, then that's different. Then you use ultrasound in that case. You don't use CT, okay? So this is just normal imaging, CT kidneys. You can see this is the, what's it called? This is the left kidney, this is the right kidney, and everything's normal here. You don't see any hyper, what's it called? You don't use any, for example, you don't see any hyper dense structure, which is a stone or anything. You don't see any masses. Okay, so renal mass, you can use either ultrasound or CT. The reason they're different because it's based on what you use first. A lot of renal masses, just as a concept, is found just randomly because, for example, renal cysts are benign. They barely do anything. However, they incidentally find it. Okay, if you do, for example, a random ultrasound, or you do, for example, a CT for another reason, they might see a cyst, okay, a renal cyst. Both of them can visualize it. The key distinction in renal imaging is what you use for stones, okay? That's the important thing. That's a very important thing. Or if you have chronic, keyword, chronic repetitive pain, you use ultrasound. That's what the difference is. Is that clear for you guys? In chronic pain, you might have hydronephrosis, okay? Because that's it. The urine is accumulating, and it will cause kidney damage in this case. So you might use ultrasound in this case to check the kidneys. Okay. So now just looking into like what renal stones look like. So here, this is an X-ray. There's like one type of renal stone that you can see on X-ray. The rest usually you can't see. This is probably a calcium stone, which is why you can see it. But there's a lot of other types. So this stone over here, you can see it. It's still in the kidneys. So if you do an ultrasound, you might actually see it. Now here's CT. It's very clear. This is a bilateral renal stone that is more hyperdense than surrounding structures. Then here, this is a hyperechoic mass with posterior, what's it called? With, acoustic shadow. Okay, excellent. So this is a hyperechoic mass with acoustic shadow. Good. So that's basically how you see renal stones. Hydronephrosis, again, you can see it on both CT or ultrasound. Ultrasound, you can see dilated renal calyces and dilated renal pelvis. And then here, the same exact thing. It's very dilated. Okay, that's basically how you see hydronephrosis. Now, if you see a renal mass, the way you can tell the difference between if it's a cyst or not a cyst is firstly look at it. If it's anechoic, no structures inside, no echogenicity, with posterior acoustic enhancement, it's a renal cyst. It's totally benign. Okay, nothing's wrong with it. However, if you have a solid renal mass, which will show some echogenicity, this is most likely renal cancer. Okay, a tumor of any form. Okay, this is very important to tell the difference. This is a cyst, not a tumor. This is a mass. Okay, it could be a tumor. You're gonna need to do biopsy after this. Now, this CT will tell you even more signs. This is a cyst. As you can tell, the cyst over here is more high. It's basically hypodense compared to the surrounding structures, and it's very smooth. It's very small. It's like it doesn't look scary, you know. If you look into this one, which is very huge, and it's basically multiple densities. Some areas in this one may be like in the mass itself might be necrotic. Some areas might be highly vascular, which is why it shows multiple densities. okay? So this is most likely a renal cancer, okay? This is basically renal tumor. Can you guys tell the difference between the two now? Okay, so we're done with the first lecture. Do you guys have any questions? Okay, so I'll start with the second one. The second one is very quick. Like there's not a lot for me to go through. A lot of the basics of ultrasound, Tariq again already covered yesterday. So if you have any questions or any points that you need to revise from the physics point of view or the basics, go to Tariq's point. So now ultrasound is one of the best modalities to use by far in general. The reason is, and this is very important to remember, it's very safe. It's very, 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 very safe. It has zero radiation. So it's very friendly to the patient. Okay. So in general, when you think of modalities to use when you don't want any radiation to the patient, think of pregnant females. Okay. So you don't want any radiation, and infants. Okay. Children. These are the two cases that you have to apply ultrasounds onto. Pregnancy, there's a bit of, basically, if it's late in pregnancy, there's a lot of things you're not going to be able to visualize, for example, appendicitis. There's maybe other modalities you can use there. But pretty much, ultrasound is very safe for pregnancy and very safe for children and very safe for everyone. But a lot of different things you need to do CT, as I mentioned already. It's very kind to the patient. It's non-invasive. It's universal and cheap. Hospitals mostly have it, and it does not require a lot of preparation from the patient. Mostly, it's just don't drink water, don't eat anything. For example, for the gallbladder to visualize it, or for example, if you want to do a pelvic ultrasound or a transabdominal ultrasound, you have to tell the patient to drink a lot of water so the bladder can be full, so you're able to visualize it. Now, the major limitation of ultrasound is that it's user dependence. What does that mean? Is that the person who's doing the ultrasound has to be experienced to look for things, because a lot of masses can be missed by doing ultrasound. A lot of things can be missed because it's very user dependent. So it requires someone with a lot of experience. And there's a lot of cases and post-surgical, for example, the doctor mentioned if someone had a scar, for example, that was painful, you go over the area, the patient screams, for example, you can't tolerate it, then you can't really use an ultrasound in that case because it's very, very painful to the patient. So there's a bit of, cons to why you shouldn't use ultrasounds. Now, in what cases do we use ultrasounds for? If the patient had pain, swelling, infection, for example, in for example, in body's internal organs, for example, appendicitis, cholecystitis of the gallbladder, stuff like that, you could use ultrasound. You can. But also, if you have, for example, a skin abscess, you can still use ultrasound there, and you can go over the ultrasound. And especially if you're, for example, doing an invasive, less invasive, but for example, if you're taking biopsy or you're draining the area, you have to use ultrasound because you need basically to guide your needle, okay, while you're doing it. So for example, if you're doing thyroid guided biopsy, fine aspiration of the thyroid, you have to do an ultrasound guided biopsy. If you're doing, for example, core biopsy of the breast, you need to do it by using an ultrasound guided biopsy, okay? Then in certain heart conditions, you use echo, which is a form of ultrasound. Now here in echo, it's to assess cardiac function. And the same thing, assessing damage after a heart attack to check for the cardiac function. Now for infants and pregnant ladies, again, same thing. It's to examine the fetus. It's very safe, very, very, very safe. So use it, for example, to check for any anomalies, which is the first thing that we're going to look into, obstetrics. So in obstetrics, we use ultrasound a lot to basically check for any anomalies in the infants. To check if they have, for example, structural defects, any, for example, cleft lip, cleft palate, to check, for example, if the patient might have Down syndrome. This is out of the scope of this lecture now, but basically to check for any structural abnormalities in the baby, okay? Use it in pregnancy. And for example, check for any placental abnormalities to, check if the baby is actually growing or not. And another step to that is you can use it and basically make it 3D or 4D images. So you can basically clearly see the baby here. You can tell if they have any structural defects, abnormalities, if they have cleft lip, cleft palate, you can clearly tell it from here, but this patient obviously normal, but you will be able to if the baby had it. That's what I'm trying to say. The next application is Doppler. Now Doppler, just to ask you guys, what does the red in Doppler mean? I know it's on the screen, but okay. Good. Okay. So the first answer, okay. So it is blood and specifically towards the probe. Excellent. So it is not just an artery. Okay. It could be anything else. It could be an artery or vein. Okay. The whole point of it is that it's assessing blood flow. Okay. It's assessing if there's laminar flow or turbulent flow. It's assessing how the blood is going through, the vessel. Okay. You can also apply it further and check if the mass, for example, that you're assessing is vascularized or not. If there's blood going towards the probe, it will appear red. If it's going away from the probe, it's going blue. So in this case over here, it's going towards the probe, that's why it's red. But this part over here of the vessel, is most likely going to be an artery, this whole thing is an artery, it has blue. This could mean that there's turbulent flow. This could mean that there is, for example, if the patient has atherosclerosis, okay, has basically lipids deposited into the walls of the vessel, okay, peripheral vascular disease, something like that. This is what this means. This is how you can assess for peripheral vascular disease, for example, one of the ways, or for example, a DVT. However, for peripheral vascular disease, there's other things I'll get to later. And so basically this picture over here shows you that this is a laminar flow. It's flowing towards the probe in one direction. There is no blue areas, meaning there's no turbulent flow. Everything is flowing in one place. This is one application of Doppler. The other application, which I'll explain through the power Doppler, is basically this. If you have, for example, this is most likely going to be the kidney, I think, because this is the liver, I think. But basically, you can tell that there is a vascularized structure, okay? This is vascular. This is very important when you're assessing masses that are cysts, that have, for example, a bit on ultrasound, for example, if you see a cyst that has some, structure inside, some echogenicity inside, then you have to do a Doppler. If there is vascularized tissue, this is most likely cancer in this case, okay? That's one application of a Doppler. Here, for example, the color Doppler will only show you if there is vascular, for example, if there's blood flowing towards a probe or away from the probe. Power Doppler is more sensitive than that. It shows you how strong the flow is, because the areas that are brighter colored have a stronger blood flow than the areas that have less color. That's the difference between the two. It's more sensitive and it basically gives you more detail, okay? So this is important, for example, if you have areas that don't receive blood supply more than rest. For example, if you have a point where you have a clot somewhere and you do a power Doppler and you can see that other areas have a very, for example, light color like this, and the areas that have the clot are like this. That's just one application of that. And the next thing is spectral Doppler. Now, spectral Doppler is just a next step to that, which is basically just showing you a measurement, okay, and it graphs it for you, okay? So, so you can think of power Doppler as showing the tissue effusion. Pretty much, it's basically will show it to you in more sensitivity than color, because color will show it to you anyways. It will show you, okay, it's perfused. However, it shows you the degree of perfusion, how perfused it is, okay? I hope that answers that question. It's just more sensitive, exactly. So yeah, spectral Doppler is basically going to graph it for you, okay? So it tells you the distance it traveled per time, rather than just a color picture, and like it shows you basically with the heartbeat, it shows you the pulse, basically, whatever. So it just graphs it for you. That's the basic concept of spectral Doppler. Okay, was that clear for you guys? Because the way that they're going to give you the questions is they're just going to write it for you, like what's the difference between, like, which of the following is true about power Doppler. You now know it's more sensitive than color. It gives you better information about the blood flow. Like, that's it. That's usually how they ask it. Or they give you a picture and they just tell you what it is. Okay, so the next thing is, as I said, pain. A lot of abdominal structures you can see from ultrasound. One of them is appendix. Now, if I ask you this, if there's a 30-year-old male who comes to you with signs of acute appendicitis, what modality will you use? Good. What if it's a 12-year-old, or not even, let's just say 7-year-old child? What modality you use? Good. That's it. That's pretty much the difference that you need to remember. How about if it's a pregnant lady? Cool. Yep. That's the concept. Okay. And this is very important for you guys to remember these. When you can use CT and when you can use ultrasound. That's very, 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 very important. For pregnant, you can use ultrasound. For infants, for children, for like these cases, use ultrasound. How about if it's a child who is obese? Okay. Yeah. You can use, so in this case, you have to use other modalities because ultrasound is very less specific. Like it won't show you the whole thing. However, Farah mentioned, you can change the frequency of the ultrasound and it might be able to show it to you in basically, if you change the frequency, there are certain frequencies that will allow you to go deeper into the tissue. And there are frequencies that will allow you to just visualize structures more in detail, but it won't go deep. However, if it's, for example, I'm very morbidly obese and you can't visualize it, you may use, for example, an MRI in this case, or you might use a CT. Okay, depends. It very depends in this case. I don't think they're going to bring you questions like this. So that's just a trick from me in this case. Inshallah, I hope. So that's it. This is an appendix, an inflamed appendix. The reason why I say it's inflamed is that the walls are thickened more than usual. Okay, and that's just how you can tell a appendicitis in this case. Okay, other cases you can use it is cholecystitis. Okay, and we'll get to that inshallah. Now if I ask you guys, how do you anatomically visualize the thyroid? What modality do I use? Good. And I'm just going to throw it. How can you functionally assess the thyroid? Okay. Yep. Iodine. So we'll get to that inshallah, but basically nuclear medicine. Okay. You can functionally assess it using nuclear medicine. Anatomically, modality of choice always is ultrasound. Here is the thyroid. This is basically the two lobes. This is one of the lobes. This is the other one. This over here is the trachea. And this over here in the middle, basically crossing over the two lobes, is the isthmus of the thyroid. Okay, this is a normal thyroid. There's no masses, there's no cysts, there's nothing. Okay, but in this one over here, you can tell that it has a lot of nodules. In this case, this is probably something like it might be cancer, it might not. In this case, it's most likely multinodular goiter, but whatever, you guys need to know that. But basically, it's thyroid nodules. It's not normal. So if they give you a picture of this is absolutely not normal. This is thyroid nodules. Okay. Right. Now, as I said, if you have certain infections, skin infections, you can do an ultrasound to assess the skin. So you can check for abscesses, for example. Here you have basically an abscess. The reason why I say it's an abscess is that it's a fluid-shaped or fluid-filled cyst, pretty much, with echogenicity inside. Okay, these echogenic materials over here, here, could be pus. Okay, which is most likely going to be pus since it's an abscess. It's a collection of pus. So this is most likely going to be an abscess. What you do here is you might, for example, if the patient is very in pain and stuff like that, you can give antibiotics, whatnot. Or like if it gets very big, you might drain it later on, but that's beyond the point. You can see here, you can use for skin infections, ultrasound. Okay. Now, very important is this. This image was from outside your lectures, but I brought it here just so you can tell the difference. Because for some reason, they did not even put like clear images to tell the difference between fatty liver versus cirrhotic liver versus normal liver. So when you look at the normal liver will all be one echogenicity. Okay, with, for example, this is, for example, a vein or an artery, basically a portal vein, part of it or whatever. Okay, it's basically a blood vessel, and the whole liver is normal. This is a normal liver. This over here is what? What is this line? Good. It's a diaphragm. Now, what happens in fatty liver is something called steatosis. Okay, steatosis basically where the hepatocytes, the liver cells, will accumulate fat. This could be due to, for example, alcoholic steatosis. This could be non-alcoholic steatosis, which is basically due to diet, okay, and stuff like that. So this case, it's a fatty liver. The reason why I say it's a fatty liver is that this liver is now more hyperechoic than the kidneys. Okay, the liver in general is more hyperechoic now. Okay, because fat in this case will appear more echogenic than the kidneys. The finding in fatty liver, again, very important, is the liver is more hyperechoic than the kidney. That's a very important finding. Versus if the liver was cirrhotic. If it's cirrhotic, this picture isn't the best picture for this, but oops, 1 second. Pretty much, this is a cirrhotic liver. It has basically, it'll have nodules and so on, and it's very shrunken liver, and the borders of the liver will not be regular at all. This will be clear over here. For example, you can see that there's a bunch of nodules over here in the liver. It's a cirrhotic liver and it's shrunken. You can see the different, basically the space now between this and the abdominal wall. And a next stage of cirrhosis of the liver will be this, which is hepatocellular carcinoma. So this is a liver tumor, liver cancer that happens with cirrhotic liver, okay? So that's how you can tell the differences. Remember the key term of hyper, in fatty liver, it's more hyperechoic than the kidneys. Remember this key term. Now, the next thing is going to be the kidneys. Now, the kidneys, you can visualize some kidney stones on the ultrasound. However, it will have to be, in the kidney. If it's beyond the kidney, you will not visualize anything. However, one thing you can visualize is this. Can someone tell me what this is on the top right, top left? Good. It's hydronephrosis. So you can see dilated, renal pelvis and calyces and so on and so forth. Here you can see a very small stone over here. It's not really clear, but it's right there, and it's causing hydronephrosis. So again, mostly acute colic, use CT without contrast. Okay. Sometimes you might use ultrasound if it's, for example, chronic, chronic kidney pain or something like that, or relapsing, and you're going to do ultrasound to assess the kidney right now. Okay, that's pretty much that. Now I added this slide just so you guys can tell what a normal ovary looks like, because most of the slides have just abnormal ovaries, and it doesn't even have a normal ovary till like a slide later on in the lectures. So I added it here just for simplicity. So here is a normal ovary with follicles. The ovary will normally have these cystic structures. These cystic structures are just the normal follicles. Okay, that's how you can tell the ovary. It's this whole thing, and these are follicles. Okay, these two. That's how a normal ovary should look like. You might have a very big follicle. That's normal. That's right before ovulation, for example. So that's absolutely normal. If you have, for example, ovaries like this, okay, this is going to be questionable now. Now, just to reference, or just to mention, that most of the pelvis can be examined through ultrasound. You have transabdominal ultrasound, you have transvaginal ultrasound, you have multiple different ways of assessing the pelvic organs. It's super, important to remember that ultrasound is like one of the best, if not the best, to visualize them. Most of the time you do ultrasound. There are some things that you better visualize through MRI, but that's after you do an ultrasound typically. Okay. So here, this is going to be for example, this is an ovarian mass. It's mostly cystic, but you have this right here. Now, how can you tell if this is a mass that is debris, for example, or a mass that is cancerous? Can someone tell me how you can tell the difference? Excellent, good. You can use color Doppler in this case, and you can tell the difference between if this is a cancer or if this is, for example, debris. Okay, because cancer, as I keep telling you guys, it will basically be vascular. So you'll see blood flow in the mass if it's cancer. Same thing over here. This is a borderline ovarian tumor. You don't need to know what that is. Just know that it is a tumor. Okay. The last two things about the ultrasound is, as I said, that ultrasound can help you, can guide you with multiple different procedures. For example, if you're doing a nerve block, you can easily just pretty much do it using an ultrasound, and it'll basically show you where the needle is going and make sure that you target the nerve itself or not. And it can help you in biopsies. And that's basically the point of this. If you are trying to, the question is asking you if you're trying to do a nerve block and you need a modality to help you in nerve block, you choose ultrasound. Okay, that's pretty much that. Now for the gallbladder, and again, I use images from outside because you're going to need to tell the difference between these three specifically. Now here, this is a normal gallbladder. You can see it's dilated, which indicates what exactly? If it's very full. What did the patient do beforehand? Good, he's fasting, perfect. Because now you have accumulation of bile, it's basically accumulating in the gallbladder. That's where bile is stored. So when it's accumulating in the bile, it will dilate the whole gallbladder. Once you eat, it will contract it. That's the concept behind that. But you can see this is a normal gallbladder, because the reason is the walls are very thin. It's normal. There's no stones. There's nothing. There's no sludge. There's nothing. Okay, this is a completely normal fasting gallbladder. Here in this case, this has a stone. Okay, this is a gallstone. Again, why is this not acute cholecystitis? Why is this only cholelithiasis? Cholelithiasis, by the way, means a stone, okay? Gallstone, that's it. Cholecystitis is inflammation of the gallbladder, okay? So the most common cause of acute cholecystitis, inflammation of the gallbladder, is gallstone, okay? So that's a way to remember that. So this is normal walls. There's no inflammation in the walls, meaning that there's no inflammation of gallbladder. There's just stone, okay? Some stones, by the way, will not cause inflammation, because if the stone starts to obstruct basically the cystic duct, or the duct of the gallbladder, then you're gonna have inflammation. Because as the bile builds up, this bile will act as a medium for bacteria to come invade. And bacteria will grow there, will cause inflammation of the walls. That's why you will see thickening of the walls in acute cholecystitis. So here, for example, you have this, which is most likely going to be multiple stones. And this whole thing, which is going to be the thickened walls of the gallbladder. So this is acute cholecystitis. You guys can tell the difference between the three now, right? Perfect. Okay, so for acute, good thing that you mentioned this. For acute presentation of the gallbladder diseases, right? Use ultrasound. Ultrasound will show it to you in like it's very sensitive. Okay, so that's that lecture done. Do you guys have any questions? That is true, but if you have cholelithiasis, you can easily tell. Like you'll be able to see the stone. Okay, and usually patients who have gallbladder diseases, they won't be able to what's it called? They usually won't be able to eat. That's just a fact. They will not be able to eat because basically with cholecystitis and so on, you have reduction of the amount of, this is beyond the scope now. You have reduction amount of bile, for example, that can go to the stomach, go to the intestines, and this will cause a decrease in the absorption of fats. So the patient will present with vomiting, with bloating, with, for example, signs of fever, and so on and so forth. The pain is very severe in cholelithiasis and cholecystitis, both of them. So the patient won't be able to eat. For colic, again, this is kidneys. Yes. For acute colic, yeah, exactly. For acute colic, renal colic, use CT. For chronic repetitive, use ultrasound. Correct. And yes, it gets worse with eating. That's why for gallbladder diseases, it literally gets worse with eating. So you will see it as is. Like you don't have to tell the patient to do anything. That's why I use ultrasound in this case. All right. All right. So now I'm going to go over the MRI basically images. Again, this is one of the two lectures that Tariq already touched on yesterday in the PAL session based on the physics of it. So now I will just continue on where he left off for the MRI, which will basically be the nomenclature of MRIs and so on and so forth. So do you guys want me to continue, or would you guys like a break for like 5-10 minutes? Sure. Okay. So starting off is based on terms. Now the term that we use in MRIs is different than the term we use in ultrasound and the term we use in CT. It's now going to be intensity. Okay. So in intensity, you have something hyper intense, or hypo intense. So if it's something hyper intense, it's brighter on MRI. If it, like, for example, this, or even better, like I'll explain it on T1 first. I'll explain the difference T1, T2 later. Is this, and something that is hypo intense, which will be darker, which is be like, for example, this. Now, explaining it on T1 versus T2 weighted images. T1 weighted image, which is this one, you'll see that the ventricles are dark. That's one thing. CSF will be dark. And apply that to spinal cord even, okay? CSF will be dark. Then you look into the gray matter and you look into the white matter, okay? The gray matter now will be darker than the white matter, okay? And why is the white matter again lighter than, okay, good, nice, okay. I didn't even finish the question, you already answered, inshallah. Anyways, so that's that, okay. So the gray matter will be darker. Now, if you have, if you use T2 weighted image, it's basically everything inversed. So now you see that the CSF is bright, okay. Then you see that the gray matter is going to be lighter than the white matter. That's it. That's pretty much the key thing that you need to tell between T1, T2 weighted image. You need to tell the difference. They'll give it to you either in statement or in image form. Okay, what's the difference between T1, T2? And for example, the white matter would be darker than gray matter. This is going to be T2 weighted image, something like that. Okay, know the difference between the two. Now, adrenal mass. T2 versus flare, I'll explain later on. So don't worry. Don't worry about that for now. Now for the adrenal mass, this is on CT. And as I said, CT, it will become more, it's hypodense than surrounding structures. Why is adrenal mass more hypodense? Good, fat, again, it's the same thing. So adrenal mass will be hypodense. And here is adrenal mass over here, same exact thing, okay? This is it over here. Just visualize it on MRI. Now this is probably T2 weighted image because of the gallbladder. It's white, okay? So fluid will appear white in this case. Now, next thing is adrenal adenoma. You can apply a next step to MRIs. And in MRIs, you can do something that is called fat suppression, okay? Now, the concept behind this is when you're doing fat suppression, you're basically cutting out all the signals coming from the fat. Just like take it as that. You're basically taking it out, all the signals coming from fat. So the fat will appear black, okay? So in this case over here, the adrenal mass will be filled with fat. So when you do fat suppression, it will be basically fully black. Okay, that's basically the concept behind it. Okay, and in CT, you see it as hypodense. In phase, you'll see it as basically normal over here. hypointense. And then in outer phase, it will be basically pitch black. Okay, so that's basically how you can tell if it's in phase or outer phase, basically by the fat suppression. Once you do fat suppression, it will cut out all the signals. Okay. Now, basically, just as fun fact, what adrenal adenoma is, it's basically very benign lesion of the adrenal gland. It probably secretes one of the, for example, if it's cortisol or whatever. That's pretty much just fun fact about that. Pretty much, yes. So now, very important is this. As I said, so when you're visualizing, for example, the hepatobiliary system, usually the first line or the first thing you do is ultrasound, usually. Now, once you, for example, detect a mass, you want to tell the difference between the mass, whether it's a hemangioma or if it's a tumor, a cancer, like a malignant cancer, okay? One of the ways you can tell that is through CT. And this is very important that you recognize this concept. So liver hemangioma is one of the benign cancers or benign lesions, tumors of the liver, okay? And hemangiomas can happen a lot of different places, but this is a liver hemangioma. Now, it's in the name, it's a tumor, benign tumor of blood, okay? Basically, it's filled with blood, okay? So this is how you can tell the difference between it and, for example, a carcinoma, which is a malignant cancer of the liver. So here you can look. This is a CT, okay? This is called gradual enhancement. So look at it as this. This is number 1. This is number 2. This is 3. This is 4, okay? Now this mass over here, you can tell it's more hypodense compared to the liver, okay? Then you want to apply contrast. Once you apply contrast, again, how do you tell this is with contrast? You look at the aorta. It's right. The way that you tell hemangiomas from CT with contrast is it will basically fill gradually from the periphery towards the center, okay? Since it's a vascularized mass, the blood vessels will have to go in, and then it will supply the outside first, then it will go deeper in, okay? Since it's filled with blood. That's how it is. So you take multiple images. So the first thing is you can see it's filling the periphery. Then it will go towards the center, okay? And that's how you have gradual enhancement. And then after basically the contrast flushes out, because you can tell it's gone now, it will basically be the same density as a liver. This is how you can tell this is a hemangioma. For carcinoma, it will basically try to retain the contrast. Okay, this won't happen. The periphery to center thing will not happen. Is that clear for you guys? Good. You guys will have to recall this also in GI next year, inshallah, when you get to it. But pretty much now. And also another thing you can use MRI for this. And this is again T2 weighted image, because you can see that you can clearly tell that the kidney has basically it's now hyperintense, and this is a whole hemangioma. Basically it's filled with blood. Okay, this is the spinal cord CSF that's bright. Again, another way you can tell this is a T2 weighted image. Now again, ovarian cancers on ultrasound. So in ultrasound, I showed you that if you have a cystic mass that has some tissue over here. Now, if it has some tissue over here, what's the next step you do to tell if it's a cancer or if it's debris? Doppler, good. So with Doppler, if it's a vascularized lesion like this one, this is most likely cancer. Okay, since it's vascular. However, if it's anechoic like this, and let's just say we applied Doppler to this one and it showed nothing, then this is not basically a malignant cancer, okay? Metastatic cancer. That's basically the concept behind it. Always when you have Doppler and it shows vascularity, always think that it's a tumor now, a cancer. And always as a concept, if you have a cyst, and you want to tell the difference between whether it's the cyst is normal or the cyst is abnormal, or if it's cancerous, apply Doppler, okay? That's usually the right thing to do. Now, MRI is very good at visualizing ovarian cancer. And you can tell the same exact thing over here. This is a T2 weighted image. And you can tell this is the right ovary, and it's very big. And ovarian cancers, by the way, just so you guys know, it's very, very huge. It's really big. Okay. And usually it presents with like a patient will have abdominal distension and a bunch of different things. Basically, it's very, very ugly. Okay. So it's very huge. That's why this one is really big, and you can see this one is very small. Okay. So this mass over here could be a cancer in this case. Okay. It probably is. So this is T2 weighted image because the fluid is very, very bright in this case. This one is T1, and it's using contrast. And just as a side note is that typically you use contrast with T1. Okay, I'm not sure why exactly, but usually T1 with contrast shows you better quality images. Okay, that's how I took it in second year. So that's pretty much that. And you can see the mass over here. Okay, that's that. Now, lumbar spine. Now for CNS, just the central nervous system, if someone has an acute stroke, what is the first, what's it called, intervention? Or what's the first modality used? Good, CT, non-contrast, excellent. Now, what if someone has epilepsy and doesn't have acute stroke? What's the modality used? If you want to visualize the brain. MRI, perfect. So typically MRI will show the brain like it's the best absolute modality for the CNS. It's the best. It's the most, like, you'll see everything. It's not the best modality to use in acute cases, okay? Because in acute, the difference between MRI and CT is instant. MRI will take like 40 minutes, an hour. You don't have that much time for acute cases. You need something very rapid and fast, you do CT. That's basically the concept behind why you use CT for acute and MRI for chronic, because you have time in this case. So this is an MRI, and you can clearly tell it's an MRI. And can someone tell me if this is T1 or T2? T1, perfect, because you can see CSF is dark. Okay, so that's basically the concept. Now, the two things I want you guys to pay attention to always, whenever you look at MRIs of the scan, of the spine, is you look into the spinal cord and you look into the CSF. The next thing is you look into this, which is a subcutaneous fat, because again, you can also apply fat suppression to this. Okay, and I'll explain that later on. Now, CT, as I said, you use it for vertebral fractures. So here, this is a completely normal, and you cannot visualize the spinal cord. You can't really see the actual tissue of it itself. Now, when you apply T2, again, as I said, the CSF will become white. This is the spinal cord right here, this thing right here. You can tell that this is the end of the spinal cord. This is the cauda equina. Okay, that's just simple anatomy in that case for the spinal cord. And this fat over here is a subcutaneous fat. And remember the subcutaneous fat because when we do, for example, something like this, fat suppression, T2 with stir. Stir, if you want to look at what it is, you can. But basically, it's causing fat suppression while visualizing water, liquid. So here, basically, this is the CSF. You can still visualize it. It's very bright. Okay. However, when you look at the subcutaneous fat, it's basically suppressed. Like it's no longer bright as you can see in this normal T2 weighted image. That's the only thing you need to remember about this. There's not much application to why this thing exists, really. And just for the sake of completion, this is just the difference between T1, T2. And this over here is going to be like these dots over here are the peripheral nerves in the lower part of the spinal cord, or the vertebral canal, no spinal cord. This is already ended the spinal cord. And you can tell this is a CSF. It's very bright T2 weighted image. That's pretty much the concept behind this picture. Okay. So now this, if you have any patient who comes to you for a ligament tear, okay, a joint injury, okay, typically this is, for example, if you have a ligament tear in the shoulder, in the knee, in the ankle, for example, the deltoid ligament in the ankle. Now you want to visualize the ligaments. And always remember, as a rule, soft tissue is best visualized using MRI, okay? So now we apply this. Someone has an ACL tear. or ACL injury. First, let's see what a normal ACL looks like. This is a normal ACL. It's this black band over here. It goes from the posterior part of the femur and attaches to the anterior part of the tibia. Okay, this is why it's called anterior, because it attaches to the anterior tibia. It's completely normal. You can't tell any, for example, edema in the surrounding structures. There's no tears. There's nothing. Okay, this is completely normal ACL. You can also see just slightly part of the PCL over here. This is part of it. It will go up and attach to here. Obviously, because it's acts like this, you'll need to like play around with the image to be able to see it. Obviously not here, but in the actual MRI. Okay, now this one. This is an ACL injury. The reason why I say this is an ACL injury is you can clearly tell that there's so much edema. There's so much inflammation going on. It's no longer the same, for example, just one structure like this. It's like it's very thick. It's edematous. There's inflammation going on. It's very bright. This tells me there's high activity going on over here. There's like a lot of fluid building up, edema again. So this is an ACL injury. Okay. So if it's a knee pain, okay, and you're suspecting, for example, a fracture, it's X-ray. Okay, if you're expecting a fracture, it's X-ray. An X-ray is typically quick. Okay, however, if someone's coming to you after, for example, a ligament tear, and there are specific signs of fracture, by the way, if it's a ligament tear and for visualizing soft tissue, it's MRI. Okay, usually if it's something very acute, if someone like actually, like for example, fell on or like let's just say had a car accident, it's usually X-ray. It's very tricky with these. If someone has a knee pain, do we order an X-ray or MRI? Typically, if it's something acute and it looks like it's a fracture case, it's X-ray. Okay, always bones, X-ray. However, if it's MRI, it's usually, for example, someone who had an injury and who was playing soccer, for example, or sport, and had ACL tear. Then the first modality is MRI. Does that answer your question? I hope, because like this was a very tricky concept when we were studying in this like last year. No one explained it to us, like which modality to use for which. And so inshallah, like I'll be able to do that this time. So now we go back to this. This is the normal brain MRI. Same things I already explained to you last time. Now someone asks flare. Now, if you have a stroke, you want to do something like this. So this is T2, okay? Now you can do something called T2 with flare, okay? So this is normal T2. The CSF bright, the gray matter brighter than the white matter. That's it. Now you can see here, there's something going on over here. This is edema, okay? Now to better visualize this edema, you do something called flare. What flare will do, the concept, is basically it will stop the flow of like this. It will basically not detect the flow of flowing fluid, if that makes any sense at all. So for example, the ventricles, the CSF, it's flowing through the ventricles. So because of this, it will appear black now. It won't detect it at all. However, if you have fluid that's building up in one location, not flowing, it will appear bright, okay? Which is what flare is. So in this case over here, it's appearing bright, okay? Because it's edema. It's a form of edema. Most likely, this is cytotoxic edema. It's better visualized on CT in this case, but if in flare, you can easily tell the edema compared to T2 weighted. Okay, what type of it? Do you guys understand flare? Yeah. Okay, I'm gonna repeat flare one more time. So in flare, you're basically stopping the pickup of signals coming from the anything that's flowing, any flowing fluid, and any fluid that is stasis, which is basically not moving, will appear bright. That's what flare is. Okay. And someone asked if what's the difference between T1 and flare? Yes, exactly. It's just the fact. You can see the white matter is darker than the gray matter. Okay, I'm going to re-explain again. Exactly. Any motionless fluid is brightened. Any fluid that's flowing will not appear. It's going to be black. That's why here the CSF is black, because CSF is flowing through the ventricles. Is that clear? Great. So now this brain tumor. So in brain tumors, what type of edema can you see? Vasogenic. Okay. In cytotoxic edema, it's ischemia. Okay. So vasogenic edema. Basically here, again, it's like MRI is you can't tell clearly, but basically you could somewhat tell that this is, for example, the gray matter and this is white matter in the edema itself. It's very tough to see in this picture. I'm not gonna lie with you. So this is the tumor in this case, and then you do T1 with gadolinium. Gadolinium again is the contrast used in MRIs. So the reason why use gadolinium in T1 is it basically helps you visualize small little points of metastasis, because brain tumors, again, it's not usually primary, it's not usually coming from the brain, it's usually metastasis from somewhere else. So it'll appear as multiple different lesions, or for example, lesions between the gray and white matter. Okay, that's just neural facts for you. But basically this is the tumor over here. It basically uptook all the contrast, and that's why it appears very bright on T1 post gadolinium. Use gadolinium mostly on T1 weighted image. I'm not 100% sure why exactly, like what's the reason behind it, but what I know is it's better to visualize masses, for example, when you do use for example gadolinium with T1, better than T2. Okay, so that's that. Now this is a brain cavernoma. Just to tell you guys what a cavernoma is. A cavernoma is basically a malformation of blood vessels and basically accumulates blood in one area. Okay, that's basically what a cavernoma is. So what you do here is in T2 weighted image, you can see that the center of this cavernoma is bright. What will bright indicate in this case is that it's acute bleed. Okay, it's bleeding right now. Okay, the black around it is called an artifact. Okay, now what this is basically showing you that there was a bleed before. Okay, why is that the case? With bleeds, you have hemoglobin, and hemoglobin has iron, and this iron will cause this artifact over time. Okay, the same thing can be visualized here. A gradient echo will help you visualize this artifact. It's much more specific and sensitive to these artifacts. Okay, it's much more sensitive, not specific, sensitive to these artifacts. So you can clearly tell it here. That's all you need to know for this. That's it. You don't need to gradient echo, I think might be covered in the physics section, but that's pretty much it. Okay. So we went through 3 lectures. Do you guys ever have any questions at all? Okay, so since Aisha just adhan a bit ago, let's take a 10-minute break and then we'll be back inshallah. 10-15 minutes. All good with that? All right. I'll see you guys then. All right. So the next part of this basically crash course will be basically covering nuclear medicine and PET. Now, as I said, this is the other lecture that Tariq covered the physics of already. So he should already covered of what beta radiation is, gamma radiation, all these things. Now I'll explain the application of nuclear medicine. Why are we using nuclear medicine in the first place? And most of these are just straight up knowing what you use for what. That's most of what it is. Okay, there's not actually a lot of specific details that you need to memorize. It's mostly just knowing what to use for what. So now 2 things is when do you use it and for what organs do we use it typically. So the whole point of nuclear medicine is that you're assessing the metabolic activity of an organ. Okay, so what does this mean? Is, for example, if a organ or a tissue, it's more metabolically active, it's more functional, it will appear, for example, as either darker or brighter, depending on if you're using, for example, CT or not with it, or not, but usually it's going to be darker, okay, on the usual nuclear medicine scans that we use. Okay. So taking that to the next point is, when is this important? For example, if you have a patient who has signs of hyperthyroidism, So if a patient has signs of hyperthyroidism, he has tachycardia, palpitations, so on and so forth, you do his thyroid, analysis or blood tests, and you can tell that he has hyperthyroidism. Now, what you want to do is differentiating the basically the causes of hyperthyroidism using this, which is nuclear medicine. So this is one application of nuclear medicine. If you have, for example, thyroid that's all metabolically active, that's one diagnosis. So it's used for diagnosis purposes. That's what the point I'm telling you. The other thing is, again, taking that thyroid case, and if you want to treat that thyroid case, one of the treatment modalities is using nuclear medicine. For example, the thyroid uses iodine, okay, as a basically to synthesize the thyroid hormones. So if you use, for example, iodine that has beta particles, it will destroy the thyroid. Okay, that's the whole point of it. So use it as therapeutic as well. Use it, for example, to check for metastasis. So if you have, for example, a bone cancer, a osteosarcoma, for example, a bone cancer that metastasizes to other tissues, you can tell by using specific nuclear medicine, basically links or specific, different, for example, technetium MDP, which is for the bone. Use specific modalities in nuclear medicine targets the bone. Okay, and that you can see bone metabolic activity. If it's just in the bones, it's normal. If it's outside the bones, there's somewhere else, this is going to be metastasis. So use it for bone scan, use it thyroid scan, therapeutics, for the thyroid, for example, pulmonary embolism, a second application of which modality to use in pulmonary embolism, bowel motility, and this is to check for inertia, okay? GIT, and this is specific for example, the hepatobiliary system. There's something called a HIDA scan, and I'll get to what that is later. And there's something, a diagnosis, which is called Michel's diverticulum. You guys probably took this last year in GI, but I'll explain what that is later. Renal imaging as well, and metastasis. Okay. Most of these you won't need to know, like, if you have a case of hyperthyroidism or a case of renal, for example, disease, which is the first line, this is typically not first line. Okay, this is after, okay, way after. Just know which basically thing you use for which organ. Okay, that's the main point of this, and for what in that organ. Okay, so that's one. So now I'll start with the bone imaging agents. So the agents here are going to be called technetium 99 something. Okay, so the TC here is called technetium. Okay, this technetium, it has something that's carrying it, basically. And this thing that's carrying it is very specific to specific molecules in, for example, different organs. For example, for the bone, typically what we use is methylene diphosphonate, okay, MDP. That's the typical one we use. So technetium 99, methylene diphosphonate, MDP, is the thing that we use, or it's the agent that we use for bone imaging on nuclear medicine. So here, basically, this is just facts on why it's, why is it specific for the bone? There's chemoabsorption onto hydroxyapatite crystals on the bone, okay? Usually the question will be, which one do you use for a bone metastasis? This is the answer, okay? That's typically how they ask these questions for these lectures, okay? It's just straight up memorization of which agent to use for what. But the main concept is these carriers, these agents, are very specific to specific organs. MDP is specific onto the bone, okay? So that's that. So its use is for bone imaging agents, bone imaging scans. This is an old one. And this is telling you why we use MDP now, technetium MDP, versus an old modality or agent that you use, which is, I think this is gadolinium 67, whatever. The point is here is that you can see that the bone, you can barely tell the difference between the bone and, for example, the liver. You can see part of the stomach here, for example, parts of the small intestines now. Same thing, here's the liver, and you can see up here, you can see the parotid glands, the salivary gland, whatever. It basically shows you a lot more than what you actually want to look at, okay? It's not specific. It's not sensitive to bone, okay? So that's why the bone to soft tissue ratio is about 1. It's equal, okay? You can see soft tissue as much as you can see bone activity. For technetium 99 MDP bone scan, you can see mostly the bone, okay? Here the bone, the pelvis is very active. This is a vertebra, very active. This is, for example, again, the vertebra, very active, or sternum even. I think this is referring to the sternum and the manubrium. And then here's the skull, for example. This is just showing you that this is very sensitive to the bone. Again, for bone scan, technetium 99 MDP. Okay. Now, a second step to application of this, why do we use it? Is to check for bone metastasis. If there's any bone metastasis, when you're using the agent technetium 99 MDP and it picks up activity somewhere that's not in its normal location, for example, here, all throughout the vertebra and stuff like that, or very, very metabolic activity in one location, it's not diffused like this is a sign of bone cancer or bone metastasis. Okay, so that's the application of nuclear medicine, is to check for metabolic activity. And you can assess it specific to organs, okay? Specific, for example, to the bone. In the bone, you use an agent, which is called technetium 99 MDP, and it targets bone metastasis. If there's bone metastasis outside of the bone, for example, in other structures, then you're gonna see that there's high activity, not in its normal location, okay? I had a question that I never asked. Does the radioactive agent not affect any tissue whatsoever? Yes. So basically, these agents are very specific, okay, to specific tissues, okay, that other tissues won't be able to pick this up. Okay, that's why here they mention it's very specific to hydroxyapatite crystals on bone, and you don't have hydroxyapatite crystals on any other structure. Okay, that's why it's very targeted to show this just the bone, okay, and bone activity. Okay. Now there's another scan, which is sodium fluoride F18. It's just same concept. It's also for bone scan. Okay. I do not think they're gonna tell you which one do we use. Okay, but for this one, it targets specifically osteoblastic activity, and it's dependent on the regional blood flow and osteoblastic activity. This is, I do not think that she mentioned this, but because this is targeting osteoblastic activity and this is in the vertebra, for example, this is very specific for one type of cancer, which is the prostate cancer, okay? Because it has osteoblastic metastasis, okay? Just a very fun fact there for you guys. I don't think you just ignore that I even said that, okay? So this is very specific for osteoblastic and blood flow. You can tell that the vertebral spine is very active, and that's pretty much the concept here. It's the same thing. It's very similar to technetium 99, for example, MDP scan. It's very similar, okay? So that's that. That's the bone scans that you need to know. MDP, sodium, sodium fluoride scan. They're basically the same. This one just depends on osteoblastic activity. That's it, okay? That's the concept behind bone scans. Now for radiopharmaceuticals, you have biological tracers and radionucleotides, which is technetium again, iodine 123 and iodine 131. Iodine 123 and iodine 131 is super, 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 super important. Like, I will stress it so much that there's the stat table in that one slide. Memorize it, okay? It's very important for the exam. But anyways, technetium pertectinate. I don't know, I probably butchered that, but anyways. This one, it targets multiple organs. So it's not as specific. However, it's very important because there's one specific diagnosis that we'll get to at the end that is very specific to this agent, pretty much. So just to read out the pharmacokinetics, it distributes rapidly in extracellular fluids similar to iodide. It concentrates in thyroid, so you can visualize the thyroid and the salivary gland. Really, radio-labeled iodine, okay? It's telling me my internet is cutting off. Did you guys hear everything I mentioned? Or should I repeat something? Okay, perfect. So yeah, as to continue, you want something that's very specific to the thyroid, such as radio-labeled iodine, which is iodine, for example, 123. Salivary gland, same thing, choroid plexus and stomach, and it's excreted by the kidneys and GI tract. Okay, so this is showing you how you can check for the thyroid, the salivary glands, the parotid gland, for example. Here's the stomach and here's the urinary bladder. This, I think, is an artifact. This, I think, is something very specific since they did not mention, but I think this is the a Michel's diverticulum. Okay, I'll explain what that is later. Okay, but this is how you can tell it. Okay, it's very diagnostic for to check for Michel's diverticulum. The thing that you use is technetium-99 pertechnetate. Okay, you need to use this one. This is very important. I think it might have came for us. Okay, but anyways, now the iodide. Okay, iodide, you want to use it. It's very important for the thyroid. Okay, now for the thyroid, if you want to anatomically assess the thyroid, what modality do you use? Ultrasound. If you want to see the function of the thyroid, a scan function, use what? Nuclear medicine. Good. Now, there is difference between the iodide agents. Okay, there's iodine 123 and iodine 131. It's very important that you tell the difference between the two, which is through here. Iodide 123 is basically used for thyroid imaging. Okay, thyroid uptake. And based on the uptake, you can see if, for example, this is a thyroid scan using iodide 123. Once you see something like this, a thyroid scan like this, know that they use iodide 123. It's always like this, okay? It's diffusely uptaken, meaning this is probably hyperthyroidism due to Graves' disease, okay? Because it's diffused. That's just a fun fact for you guys. You don't need to know that. But just know for imaging of the thyroid, in terms of the function, in terms of thyroid uptake scan, use iodine 123. The next thing is you can actually treat thyroid diseases using iodide radiopharmaceuticals, okay? Or radio-labeled iodine. This one is different. This is iodide 131, okay? This one is for thyroid ablation. Basically what thyroid ablation is that this iodine is, it's specific, it's called iodine 131. Because it's iodine, it will be uptaken by the thyroid because the thyroid depends on iodide to synthesize thyroid hormones. So it will take up the iodine, and once it takes up the iodine, the beta particles, which is very important, the emission is through beta particles for iodine 131, would basically kill the thyroid from within. Okay, so this we use it if we don't want to do surgery for the thyroid because there's a lot of risks for the surgery of the thyroid. We use this, okay, which is radio-labeled iodine. And this is called radio-labeled ablation of the thyroid. Okay, and this emits beta particles, which will kill the cells. Gamma particles will not. Okay, gamma particles are just for the uptake and just for visualization. Okay, so you can see this is diffusely uptaken. And just to mention why this is a functional scan and this is not anatomical, is because you cannot see, like, for example, the different lobules and whatnot. If the patient had something called a thyroid adenoma, which is basically a mass, a benign tumor that's secreting a lot of thyroid hormone, one area only will become dark. Okay, that's just why we use it as a function. Okay, because it helps us differentiating different thyroid diseases. Okay, so we use this to basically for thyroid uptake. Okay, is this clear to you guys? Remember this for the exam, please. Okay, remember this exactly. Now, the next thing is you have a patient who, again, I'm going to use the same exact patient I used last time. I think I said postmenopausal woman who had acute onset of very severe, what's it called? For example, respiratory distress and shortness of breath. Thank you. And what's it called? They just had like a 12-hour flight. What are you suspecting? Pulmonary embolism. The first thing you did before was CT scan with contrast, and it didn't show you anything because if the emboli isn't that big, you won't see anything. Okay, you won't. That's basically how it is. But if you have, for example, pulmonary embolism that's not that big and you won't see it on CT scans, you need to do something else. The one thing you do is something called a VQ mismatch or VQ scan. VQ is basically ventilation perfusion scan. Okay, the ventilation point is basically it's trying to see if the whole lung is ventilated. Air is getting to all parts of the lung. Perfusion is blood is getting to the lungs. Okay, that's the difference. Now, next step. How do we assess the VQ here? So with ventilation, we do something, we basically label the air or gas with, and it becomes radio-labeled gas. It's called KR, okay? We use radio-labeled gas, okay, for ventilation. Now we give it to the patient, they breathe it in, and we can see the whole lung over here, okay? So it's fully ventilated. Now we want to see if it's perfused. We use radio-labeled albumin because in blood, okay, what's the most abundant protein? Albumin, okay? So now we radio-label this albumin with technetium, and you'll be able to assess the whole lung perfusion. So now next step, how do we use this in pulmonary embolism? And why does it show a mismatch between ventilation and perfusion? In pulmonary embolism, all that's happening is you have a clot, an emboli, that's traveling to the lungs, and it's basically blocking one of the pulmonary vessels that's supplying the lungs. So now that you remember this and you know this, one part of the lung will not be perfused. However, when they breathe in, the patient breathes in, everything's ventilated. The trachea, the bronchi, everything is normal. There's no obstruction there. It's obstruction only in the vascularity. So with the VQ mismatch, basically there's going to be higher ventilation and lower perfusion. So how can you see this here, and how can we apply this here? You can see this is normal perfusion. We use radio-labeled albumin with technetium. This is going to be the right lung. This is the left lung, okay? And you can see the whole thing over here. Everything is perfused well, okay? There's no filling defect, if you want to call it that. Versus here, this is a filling defect in the upper part of the thyroid. Sorry, not thyroid, lung. Okay, upper part of the lung, there's no perfusion there. However, when you look at the ventilation, everything is normal. Okay, it's well ventilated. That's the concept between a VQ mismatch and pulmonary embolism. Do you guys understand this? Or do you want me to repeat anything at all? Perfect. Okay. All right. The next thing is bowel motility. Now with bowel motility, one of the things that we can do to check for bowel motility, if the patient has constipation, if the patient has constipation due to, for example, obstruction, or constipation due to, for example, colonic inertia, which is basically the muscles of the colon is no longer functional due to a nervous system thing, or not the nervous system itself, but basically the intrinsic nervous system of the GI, okay, what's it called? The cells of Cajal, okay, if you guys remember that. Basically, it will automate the contractions, the peristalsis of the colon, okay, of the whole GI. So if this is not working, the whole colon itself will not be able to push, for example, the stool downwards. So you'll see that the patient will have constipation, okay? The same thing if you have basically a bowel obstruction. In bowel obstruction, you won't have the stool going past the area of obstruction, okay? So that's that. Now, when we assess it, we're trying to see if it's due to a functional obstruction or if it's due to, for example, dysmotility, okay, which is basically inertia, okay, colonic inertia. We do this by using, for example, technetium 99 technetium, whatever, iron 111, or gallium 67. Okay, this is, I don't know if it's important or not to remember these specifically, but remember the next slide. This. I'm going to explain now the normal. Here, this is the normal. This is going to be the cecum. This is the ascending colon. This is going to be the hepatic flexure, transverse colon. Splenic flexure will be here. This is the descending colon. Here is going to be the sigmoid colon, and then rectum, and then, yeah, the anus down there. So now, over time, usually when you have, for example, you give the patient, for example, radio-labeled technetium, they swallow it, fluid, for example. It will stay, or anything like food, with food or whatever. It will stay in the stool for, or in the colon for a while, okay? So you check how far it traveled over time. So 24 hours later, you can see it's all over the ascending colon, and it's mostly going to be in the hepatic flexure and transverse colon. Then it travels past the, at the distal part of the transverse colon, and it's going to go to the, the splenic flexure. Some have already gone down to the descending colon. Then 72 hours later, barely anything is there. This is absolutely normal. Okay, 72 hours, everything should be gone. Okay. Now, think of this. If the colon itself is not doing peristalsis, it's going to be way slower. Okay, way slower. So you're going to still see activity going on where it should be gone already. So for example, over here, this is the descending. The image is slightly not the same as this, but just follow with me. This is the ascending colon. This is going to be one of the flexures, is the hepatic flexure, and this is transverse colon. You can see it's going up the ascending colon, it's going to the hepatic flexure, fine. Then in the transverse colon, nothing's going down to the descending colon. Even 72 hours later, everything is stuck. This is what we call colonic inertia, okay? Everything, basically the peristalsis, it's not there anymore, okay? This is what we call colonic inertia. Stool is just stuck at one point, okay? And it's not obstruction. Functional outlet obstruction is usually going to be somewhere in the rectum or anal canal, okay? That's why in the functional outlet obstruction, this is the ascending colon, transverse over here. It goes past the transverse, normal. Everything is normal so far. Down the descending colon, and it's everything is stuck at the rectum because there's a functional outlet obstruction, something at the anus, okay, or at the distal part of the rectum. Something is obstructing that. The next thing is generalized slow colon transit. Basically, it's the same as normal, but everything is just slow, okay? It's very, very, very slow. That's pretty much all that it is, okay? So you can see it's going up the ascending colon, all normal in 24 hours, some in the transverse colon, everything is fine. However, it's very slow. Most of this already should be in the descending colon. However, here you can see some already got to the descending colon, but there's still stuff inside, okay? But which means it's very generalized slow, okay? Is this clear to you guys? Or you want me to repeat something? Perfect. Well, that's basically this. You need to tell the difference between the pictures, okay? And hopefully if you followed me with this, and you can tell the difference between normal and colonic inertia functional outlet versus generalized slow. Colonic inertia, again, everything just, it's not functional. However, with slow colon transit, from the name, it's just slow. Okay, that's it. That's why it just takes more time, more than 72 hours for it all to go out. Okay, all of these will cause constipation. Okay, or like causes of constipation. So that's that. Now for this, which is Michel's diverticulum. Just for you guys' info, Michel's diverticulum is basically a remnant of a duct that connects the umbilicus to the midgut in embryo, okay? And it's remnant because this duct should close, okay? It's called the vitelline duct. It should close. But if it doesn't, it forms a diverticulum, which is called Michel's diverticulum, okay? Now, usually it happens in kids, and the most common symptom in this case for children is usually a fresh GI bleed, okay? Or a fresh passing of blood from the stool. Just fun facts for you guys. Diagnostic modality for Michel's diverticulum is technetium-99 pertechnetate. Very important. Very, 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 very important. Okay, that's it. That's all you need to know for this. Okay, that's pretty much it. And it's basically targeting basically Michel's diverticulum will usually have different cells in it. It usually will have mostly gastric cells, but however, it can have pancreatic cells. The gastric cells, or you have the mucus secreting cells of the stomach in the Michel's diverticulum, will be what's getting targeted by the technetium pertechnetate. Okay, so that's that. The next thing is called a HIDA scan. The agent that we use is a technetium-99 IDA scan or aminodiacetic acid. Basically, what this is doing is basically you're visualizing the whole biliary system. Okay, this helps you visualize the biliary system. It targets the bilirubin, which makes sense. Very important. I'm pretty sure, yeah. And it assesses the function of the gallbladder and the biliary system. That's all you need to. Okay, an image modality, like not modality of choice, but if you have a question on which nuclear medicine agent to use for visualizing or assessing the function of the gallbladder and biliary system, you do IDA or HIDA scan. Okay, that's basically what this is. What is the image modality of choice, however, if you want to assess the gallbladder and the biliary tree? Ultrasound, good. Perfect. That's it. Now, this is the same thing again. I really highly doubt they would like you guys to like interpret whatever this is. So honestly, I don't think you guys need to know what this is. Okay, just whatever I mentioned here, HIDA scan to visualize this, to visualize the biliary system and the gallbladder. Now, the next thing is sulfur colloid. Now, sulfur colloid is very specific to the reticuloendothelial cells. This is important for visualizing, for example, the spleen, the liver, and even some in the bone marrow, okay? Basically, all will come from the precursor, hematopoietic precursor, whatever. It's all from the reticuloendothelial cells. So this is important, for example, if you have a patient with sickle cell anemia who has, for example, autosplenectomy. When you do sulfur colloid, you will not be able to see any function in the spleen, which is this over here. That's how you use it, okay? Or that's what's important about it. It's used for liver spleen imaging and bone marrow imaging. That's all you need to know about sulfur colloid. Used for targets reticuloendothelial cells, used for liver, spleen, bone marrow imaging. Okay, usually it's liver spleen is the most important thing you need to remember for this. Okay, once you see spleen or reticuloendothelial cells, sulfur colloid does the answer. Okay, so that's pretty much that. Now, renal imaging. I highlighted or I underlined the two that, based on you guys' transcript and recordings, the two that the doctor really wants you guys to know. But I'll go over everything, whatever is on the slides, basically. So the first one is technetium-99 pentatate. And technetium-99 pentatate is very important. It's a nuclear medicine modality of choice for renal perfusion and renal clearance. That's all you need to remember for this. Technetium-99 is for renal perfusion and renal clearance. Okay, technetium-99 pentatate. The next one is DMSA, which she wants you guys to know about this one and what's it's used for. Again, the same thing. The ones in red. I put this in red based on your transcript. Used to assess renal parenchyma. Once you see which form of technetium, which agent, DMSA is the answer, is used to assess renal parenchyma, it's DMSA or succimer. Okay, that's it. That's literally the points that I want you guys to focus on mostly in this. They never usually ask about the pharmacokinetics, usually never, but just read over it and understand it. Usually they ask about this. Okay, so here the application of the DMSA or the succimer, technetium succimer or DMSA. Here is a normal renal parenchyma. Everything is normal. If it's abnormal, it won't be all active. Okay, so for example, there's some parts that are not active. Okay, this is just showing you the renal parenchyma. There's something wrong with it. That's all. Okay. Now for MAG3 or whatever, the technetium MAG3, it's basically to assess renal function. And that's what you need to know about this. Renal function. Know the images, by the way, because if it gives you this, it'll ask you which one we use, and it's DMSA. For this one, it's MAG3. The reason is because of this. It's assessing for renal function. What's the function of the kidneys? It's for filtration, excretion. Okay. If it can't do that, it won't appear at all. That's the function of the kidney. Okay. So this is abnormal because this whole right kidney isn't doing its function, which is excretion or filtering at all. So that's why it's not appearing at all in this one. MAG3, it's for renal function. Okay. And this is just application of it. I'm not sure what this is specifically, but know it from here. Okay. And I'm going to skip this as well. I don't think you need to know what this is. Was all of that clear so far? Perfect. Now the next thing, which is another application of what's it called? Nuclear medicine. The other application of nuclear medicine will be in the form of PET-CT, okay, or PET scans. Whenever you have someone who is already diagnosed with cancer, specifically, for example, lung cancer or lymphoma, that's what the doctor wants you guys to know, is you want to stage the cancer. You want to see how bad the cancer is, because this will affect how you treat the patient, obviously, okay? There are certain chemotherapies that you can use only if it's, for example, stage 3 or whatever, or you can use only surgery for stage 1, whatever. So you want to know this by doing PET-CT, okay? Now, the two cancers they want you to know is lymphoma and lung cancer, okay? And just remember this. Use PET-CT or FDG PET-CT for staging of cancers, for checking after you start treating the patient, if the treatment was effective or not. So checking the response to the therapy, because if you start giving chemotherapy and the tumor shrinks and it's not as active, you can pick it up through PET-CT. And investigating the fever of unknown origin. So basically what this is, just for you guys' concept, is you have a patient with a fever and you do a bunch of tests, you check for bacteria, you check for everything, there's nothing that appears. This is what fever of unknown origin is. It might be a specific type of bacteria, which is called Brucella. No, you don't need to know it. But when you are trying to look for fever of unknown origin, you do PET-CT. Now, what is PET-CT? PET is the nuclear medicine part of it. CT is the anatomical part of it. Now you're just combining the two. So you're going to see parts that are very biologically active, and you're going to see it in, for example, a CT scan. So you're going to combine the best of both worlds. You can see which one is functional, and you can see where it is exactly through CT. That's basically combining the two. Here is this in lymphoma staging. Lymphoma is obviously a cancer of lymph nodes, and here you can see the lymph nodes, okay? This is just a normal CT. Now, once you do a FDG PET, okay, which is just PET scan, FDG is basically just the agent for it, just for you guys' info. Once you do the PET scan, you can see where the lymph nodes are, okay, just based on biological activity, and it basically metastasizes to other areas. However, once you do fused FDG PET CT scan or PET CT scan, you can see where it is exactly and its biological activity. You're basically combining the best of two. Use it when you're staging cancers, okay? Because now you're able to see where it is, where the cancer metastasized to, and if it's biologically active or not. This is probably the primary source of it. This is the metastasis, okay? Now here, you gave this patient chemotherapy, and afterwards you're assessing if it got treated or not, okay? Or if it's responding to chemotherapy. So response to chemotherapy, either it didn't work or it did work. How do you know if it did work? If the tumor has shrunken, if the tumor is now less biologically active, okay? Then you'd see this. This is just normal CT. You can see it's slightly smaller than this one, okay? But it might still be very active. So you do FDG PET. This is the normal PET scan. And you can see here, this is still biologically active. However, you want to now combine the best of two worlds, you can see this. Now here, if this is the same patient as this is no longer active as it was over here, as much as that. So this is responding to chemotherapy, responding to treatment, okay? So that's basically how you use it. For staging cancers, when you first diagnose them, and post-treatment to check if it's working or not. And this is just showing you lung cancer. It's the same exact thing that I mentioned. It metastasized to the lymph nodes. You can see hilar lymph nodes, they're active, and so on and so forth. Okay, it's spreading to lymph nodes. Now, another thing is, why did they put adrenal here? Lung cancer, a very specific location. Once you see an adrenal mass with a patient with known lung cancer loves to metastasize to the adrenal glands. It loves it, okay? So you do this and you check for the adrenal glands, you can see that it's biologically active now, even in the adrenal glands. However, this is the primary one in the lungs. Okay, so now it metastasized to the adrenal glands. It's the same thing. So this is checking for staging. Since it's metastasized to another tissue over here, this is stage 4 cancer. Okay, so that's just how you can tell that from nuclear medicine, from PET CT. Okay, this is normal PET in this case. But use PET scans to stage cancers. Okay. Now the last thing, which is just another application of PET, you can check for neuroendocrine tumors, such as carcinoid tumors. And just for you guys' info, just for the sake of completion, carcinoid tumors are basically neuroendocrine tumors from like the slide, but basically it secretes active molecules, which are usually serotonin. So in this case, the patient will have signs of high serotonin in this case, and it's usually from the GI. Carcinoid is usually from the GI. Okay, so that's that, and you target it using gallium, and then you have choline for other things. And I don't think you need to know choline because there's nothing specified for it. That's it. Do you guys have any question for nuclear medicine? Okay. Last 2 lectures, and they're pretty easier, honestly, than the rest, because this is just knowing the differences based on images mostly, and just some simple facts, like, for example, when do we use this, when do we not use this, and so on and so forth. I think so. to answer your question. Pretty sure. Okay, so now we're going to go to imaging of common malignancies. The main thing in this lecture is breast cancer. You guys will get a lot about breast masses. Okay, you need to tell the difference between a cyst versus a fibroadenoma versus microcalcification versus a cancer. Now, breast cancer, just to give you guys an overview, it's one of the most common malignancies here, and it says it's the most common malignancy in KSA. Worldwide, it's usually the second most common. It has a very high mortality because it's usually discovered very late. Okay, either it metastasized to lymph nodes, which is very important for this lecture also, or metastasized to other tissues. However, something very good about breast cancer is that there's a screening for it. Okay, usually any females above the age of 40, they get screened using annual mammographies. Okay, screening is by mammographies. Okay, just remember that, mammography. Okay, even if they're asymptomatic, it's just for screening. Okay, completely normal breast, you still have to annually assess it. Okay, remember the cutoff of age of 40, because I've seen a question or two in the past about that. However, if the patient is symptomatic, okay, if the patient comes to you with a breast lump, then you have to do something else. So now, in this case, if it's a very young patient, for example, in their 20s, you might need to use an ultrasound in this case. Okay, I'll explain why later. However, if it's above the age of 40, use a mammography. I'll explain again why in that case really later, like the next 2 slides or something. Okay, and you check if they have a prior history of breast cancer. You need to check if they have metastasis, and you need to check for what specifically. Okay. Now, the 2 ways you image the breast is do basically the mammography. It's 2 views. There's something called craniocaudal and basically mediolateral oblique. So to explain it here, this is the normal craniocaudal view. The whole thing is it's looking at the breast from up down. Okay, so if it's looking from above, okay, that's where the image is coming from above the breast. This is going to be, for example, might be wrong, medial. This is lateral. I'm just giving you those for concept. It's looking from above. So if you're going to see above, this is medial, this is lateral. Okay, that's what craniocaudal is. Mediolateral oblique, MLO, you will see it from basically superior and inferior. Okay, up, down. How do you know this is MLO? Can someone tell me why this is MLO? Very important sign here. Exactly, good. This. Okay, that's your muscle. Another thing you can see from MLO is something called, I'm not sure if she's mentioned it for you guys, but basically the mammary fold, okay, which is below the breast. Okay, you might see it here. But anyway, that's just another sign to why this is MLO. The most important thing is look at this. Once you see this, you know that you're looking at MLO view. Now, a concept here. The breast has two things you need to look at. You need to look at the glandularity of the breast, which is going to show as more dense breast. And you need to look at the fat concentration. Now, typically, as a female age, in their 20s, and especially during pregnancy, the glandularity will be very high. Okay? Reason is because the glandular tissue is dependent on estrogen. Okay? It's dependent on progesterone. These two. The glandularity, estrogen, make it more dense. Okay? After the age of 40, for example, or around 40 to 50, where the patient has menopause, which is basically where it's not, basically the menstrual cycle is no longer the same. Estrogen will decrease. The glandularity will not be as much as before. So you'll have more of a fatty breast. Okay? That's what's important here. This is why in younger patients, because of a more glandular and dense breast, you might need to use an ultrasound. I explain why. Now, this is something called BIRADS, okay? And basically, it's a scale 1 to 4, or A to D, more typically A to D, not 1 to 4. A to D, that's basically checking for the glandularity. A is glandularity of 1 to 24. This is showing you a more fatty breast. Okay, so you expect this in a very elderly woman, above the age of 40 to 50. Okay, here, this is glandularity of 25 to 50%. Okay, then you get more glandular, which is going to be C, then D, which is very high glandularity. This you might see in pregnancy. Now, if the patient tells you, I felt a breast lump, a mass, if you do a mammography, can you tell anything from here? Anything at all, if it's a very glandular tissue? No. What can you use instead? Ultrasound, exactly. Ultrasound will be able to pick it up. That's why I said, usually if it's like a breast lump in the age of 20, something like that, you might need to use ultrasound in this case. Or as the question might come to you guys, if the breast was very glandular, what do you use? Use ultrasound, not mammography. Okay, that's the thing. But above the age of 40, you typically use mammography instantly because it's going to be less glandular. That's just how it is. Okay, so that's, I hope the concept with that's clear. So this is just normal increased density and more glandular. This is basically the what's called MLO. And then this one is craniocaudal, it's up to down, and you can see it's very glandular. So if you have a mass over here, you won't be able to tell what this mass is, or you won't even be able to see it. So you need to use ultrasound in this case. Now to look into calcification. Now for you guys, I will mention, there's two types of calcification. There's macro versus micro calcification. This is macro calcification, okay, which is big, okay? This is a benign calcification, absolutely benign, absolutely normal, okay? Nothing to worry about here. If you see a patient with this on mammography, absolutely normal, okay? This is macro calcification or skin calcification, okay? Just don't remember the skin part, but this is macro calcification. If you see this, this is benign, normal, okay? This is the second thing, which is called vascular calcification. And this is normal as well in the breast, okay? This might be another pathology somewhere else. This is calcification in the blood vessels, okay? Not a pathology of the breast. This is why it's a normal benign calcification in the breast, okay? Which is vascular calcifications. Recognize these two, please, and just know that it's benign. It's not malignant. It's not a sign of anything like dangerous, okay, for the breast. Then you go to see this. This is what we call microcalcification. If you see something like this, okay, this is craniocaudal view. If you see microcalcification bundled up like this is malignant calcification. Call this for now microcalcification. Okay, this is more likely to be malignant versus macrocalcification. Just know that. Now we go into a magnified view, and you can see this is microcalcifications. No, the diagnosis, the name of this, don't say it's a carcinoma, because you don't know. Unless later you do, for example, a specific type of biopsy. I'll get to that later. But this one, if it's microcalcification, call it microcalcification. Okay? Please, because we were questioned on this last year, and a lot of us got it wrong by answering carcinoma. It's not. It's just microcalcification. It's most likely to be a malignant. However, as you'll go when you go to third year, you'll know that there are other types of microcalcifications that are not malignant. However, once you see it, you might think of it. Okay? So is that concept clear to you guys? Cool. Again, answer microcalcification for this. If you see any of these three pictures and you see the microcalcification, answer microcalcification. Next thing. What if you see a lump in the breast? Okay, like this. You're going to need to know if this is cancer. You're going to need to know if this is, for example, if this is a fibroadenoma, or if this is, for example, a cyst. Okay. Now in this one, since, what's the problem with this patient here? Why is the lump not that clear? Exactly, perfect. It's very glandular. So in this case, what would you use? Ultrasound, that's it. Okay, so I'm going to use ultrasound in this case. So in ultrasound, this is very important. that you tell the differences between a cyst, fibroadenoma versus invasive carcinoma. So the features of a malignant lesion on an ultrasound are this. Firstly, look at the borders. Can you clearly tell and just like visualize where the borders are of this? No, it's irregular, exactly. You can't really tell where the borders are. And then it's hypoechoic, okay? And hypoechoic lesion is the same as fibroadenoma, okay? However, you can't tell where the borders are. You can't tell where the mass is and ends. Why? Because it's invasive. It's going into the surrounding structures. It's not just one mass. It's just going into the invasive, like into the other structures in the breast. The other thing is you look at the chest wall. If it's parallel to the chest wall, this is fine. If it's perpendicular or vertical or anti-parallel to the chest wall, this is a very malignant feature. Okay? So two important things that you'll see here is that it's anti-parallel and it's irregular. Okay? The borders. That clear? Okay. So now this. Can someone tell me what the possible age of this patient is? Good, excellent. It's above 40. Reason is because it's fat. You know, it's fully fatty breast. Okay, there's less glandularity. Now here, this mass is kind of smooth, but you know, you might want to do, for example, ultrasound to check what this mass is. The reason why you want to do ultrasound here is because once you see a cyst, it looks very similar to a fibroadenoma, very similar on mammography. So you do ultrasound to tell the difference between the two. Okay, so once you do ultrasound, this is what you see for a cyst. Just like any cyst that you see. What are the two features of any cyst? Anechoic, posterior acoustic enhancement. Excellent, good. That's it. Anechoic, posterior acoustic enhancement, right here. That's it. That's a cyst, breast cyst. Fibroadenoma, what a fibroadenoma is basically a benign mass, okay? It's one of the most common breast masses that you'll get. It's very common in, for example, in females in their reproductive ages, and it's responded to estrogen. And these are just facts for you guys to remember. Don't remember, it's fine. What you need to know is how you could tell this is a fibroadenoma. And how you can tell this is a fibroadenoma based on the features that we discussed for malignancy. Is this parallel to the chest wall? Yes, it is. If it's parallel, this is a benign feature. This is a feature of fibroadenoma. As I said, it's hypoechoic. It's still hypoechoic, plus you can see some calcification-ish, you know, type structures inside, whatever. Just know that it's parallel, and you can tell the borders of this very clearly, okay? If you see a border, clear border that's smooth, and it's parallel to the chest wall, fibroadenoma. If you see anechoic and posterior acoustic enhancement, breast cyst. If you see if it's anti-parallel and the borders are not irregular, this is a malignancy, invasive carcinoma. Know the difference between these three on ultrasound. Very important. Okay. Another thing is you can see this feature of fibroadenomas on a mammogram, which is basically called a popcorn calcification. It's just bundled up calcification like this. This is a sign of fibroadenoma. Plus, if you see the borders of this, it's kind of smooth. So this is a sign of fibroadenoma. If it's a breast malignancy, it's gonna, and if it's a mass that can be shown through mammography, it's going to be, for example, speculated. It's irregular borders. It's like a star shape like this. It's very not like smooth border like this. Okay, so that's that. Here's all three different, like all three structures that you need to identify on the ultrasound. Now, the concept of sentinel lymph node. The most important thing for the prognosis of breast cancers are the sentinel lymph nodes, or the lymph node metastasis. Okay, very important. Now, instead of just going in and taking out lymph nodes and then doing biopsies, we have something called sentinel lymph nodes. Just remember the concept of sentinel lymph nodes is basically checking if this cancer has spread to the very first lymph node closest to the breast. That's what a sentinel lymph node is. You inject it in the tumor, basically a dye, and it goes to the nearest lymph node. okay? If the lymph node also colors up, I think this is what it is, then it's a sign that it's spread to the lymph node. If it doesn't, then it washed away, then khalas, okay? I think this is a concept, but just as for you guys to remember is that you use sentinel lymph nodes to check if the breast cancer had metastasized to lymph nodes. Okay, that's pretty much the concept behind it. Okay, that's it. Are you guys all good with the breast? Good, alhamdulillah. So next is thyroid lesions, very easy. Again, modality to use for thyroid is ultrasound. You can clearly tell this is a cyst. This is a trachea, as we mentioned before. This is just showing you the right thyroid gland, and this has a cyst. And as any cyst, it's anechoic and posterior acoustic inhabited. Okay, this is most likely a jugular vein, okay, or the carotid. But this is most likely jugular vein. Anyways, this thing over here is a thyroid nodule, which could be cancer. Okay, that's it. I mean, that's basically the whole point of the slide, just tell the difference between a cyst and nodule, and it's very easy to tell the difference between the two. Now, this we already mentioned, so I don't think I have to repeat this part anymore. And for a lot of this will be just repetition at this point. So for renal cyst and renal solid mass, if it shows cyst features, which is anechoic, posterior acoustic enhancement cyst, solid mass, it's echogenic, and it's most likely cancer on ultrasound. If it's a cyst, it's a smooth, small, and hypodense, okay? Compared to surrounding structure on CT, okay? If it's a solid, or if it's a malignant cancer of the kidneys, such as this one, you can see it's very big, it's ugly looking, and it has multiple densities because some parts, as I mentioned, could show necrosis, and some parts are just the tumor itself. And this is very specific for one type of cancer of the kidneys. Now this, ovarian cancer. So this is going to be a normal transabdominal ultrasound. You can see the uterus and you can see the ovaries. And this is just basically looking from above, okay? So this is the uterus and this is the two ovaries. You might appreciate the fallopian tubes. You might not, but anyways, these are the two normal ovaries. This is transabdominal. So yeah, in transabdominal, what do we tell the patient before we do transabdominal ultrasound? Drink fluids. Excellent. Good. The reason is because you want the whole urinary bladder to be full. So because with fluids, it will basically the sound waves will travel more. So you can see the uterus here. It's not the best looking ultrasound for the uterus. We'll get to that in later. And this is the normal ovary. You might see the fallopian tube or the broad ligament. Okay, but that's basically that. Now this is normal ovaries, and I already showed you guys another image before of what the normal ovaries look like. This is just, again, the follicles, normal, okay? Everything is normal, it's small, there's nothing wrong with it. Same thing over here, okay? These are just follicles. Now, if you have a cyst in the ovaries or anywhere, okay, and it shows some echogenicity, what do you do now? Doppler, excellent. If it shows there's vascular activity, what could this be? Tumor. If it doesn't, not a tumor, hemorrhage. Okay, it's basically bleeding into the cyst. Okay, so this is hemorrhagic because it's just debris. Okay, it's just hemorrhage into it. The reason why it's not it's not showing up on Doppler is because it's not active flow towards the probe. It's just sitting in the cyst, like the blood itself. It's accumulating in the cyst. That's all. It's not flowing because it shows flow. Doppler shows flow. Okay, that's why on hemorrhage, hemorrhagic cyst won't show anything. Okay, but you can see the surrounding. This is a blood vessel and it's going away from the probe, the blood. Okay, the concept clear? Cool. This is a complex cyst, the same exact thing that I just mentioned. Since there's echogenicity, you're going to do Doppler. It's the same exact image as we did before, as we showed before. And you can see it's vascular, there's blood supply, there's active blood flow in it. So this is most likely cancer. And this is it on MRI, as we mentioned before. Now, endometrium, you're going to need to know the difference in transabdominal, transvaginal. And the difference is urinary bladder. MRI for ovarian cancer, it's very specific for ovarian cancer. You can visualize ovarian cancer very well with MRI. Very, very well. Okay. Usually for pelvic organs, the first thing you do usually is ultrasound. However, then the next modality you might use is MRI for ovarian cancer. If you see, for example, this. Okay. Now, what's it called? Transabdominal, you can see the urinary bladder, and this is the uterus. It's a normal looking uterus. There's nothing wrong with it. This is the vagina, cervix will be here, and this is the uterus. You can't really appreciate the endometrium here or the myometrium, but you can here. This is the transvaginal view. And basically it's putting the probe into the vagina. Okay, that's basically that. And you can see the endometrium from there. And you can see the endometrium, the walls of the endometrium, you can see the myometrium. This over here, this lining is called the serosum. Important to know because of a pathology in the uterus, which is called fibroids. Fibroids can happen in multiple different areas. They don't explain this to you. This is explained to you later. But, okay. Fibroids can be in multiple locations. It can be subserosal, which is below the serosa, but above the myometrium. Okay, so this is subserosal. Okay. Intramural is if the fibroid is in the myometrium. And you might ask, what is a fibroid? Fibroid is basically another name for it. It's called a leiomyoma. From the name, leiomyoma means that it's a benign, smooth muscle tumor. It's a benign, smooth muscle tumor. Okay, so this is going to be if it's in the myometrium, it's an intramural. It's in the walls itself, which is going to be the myometrium mostly. Subserosal will be below the myometrium, but within the serosum. Okay, so that's what the fibroid is. This is just a normal thing again at the same time. Now, endometrial atrophy is if you look into the this endometrium, you can see that you can clearly tell that this is the endometrium and it's thick, a bit thick. This might be relevant to the phase of the menstrual cycle, but don't worry about that at all. Just know this is a normal endometrium. If you see something very thin and slender like this, this is endometrial atrophy. Okay, this might happen postmenopausal. Okay, this is something that usually happens with most postmenopausal. Okay, so this is endometrial atrophy. Then this, which is endometrial cancer. Why is this cancer? Because there's active blood flow into the mass. Okay, which is a sign of a cancer. Okay, so that's pretty much that. Because in Doppler, you can see there's active blood flow. Is the pelvic organs and pathology good for you guys? So we move on to lung. Cool. Just know the images very well because they probably will ask you about. Now, for lung cancer. Now, if you have a suspected lung mass, a patient with a suspected lung mass, what's the first modality you use? X-ray. What's the most specific and sensitive? CT. Good. Perfect. That's pretty much the concept behind it. And which window do you use in CT? Great. Perfect. So this is a lung mass or a cancer, okay, whatever, a mass. You can't really tell where it is. You do a CT and you can clearly visualize it. It's going to be in the hilum, okay? This is it in the hilum. So then once you diagnose that this is lung cancer, it's close to the hilum. So this is one type of lung cancer. So then you want to stage the lung cancer. And what do you use for staging of the lung cancer? This is a soft tissue window, yes. But typically for example, lung mass, if it's in the lungs itself, this is in the hilum, for example. If it's within the lungs, you use a lung window. But yes, this is the tissue window, soft tissue window. More broad than that, PET. Yes, exactly. Okay, so you do a PET CT in this case, and you check for metastasis or into the adrenal gland. Okay, as you said. More specifically, just PET scan. Okay, and more broad generally. If you want to go specific, yes, adrenal metastasis or lymph nodes. Okay, so it's basically what we covered in the nuclear medicine lecture. And then here, the same exact thing, which is adrenal metastasis. If this is in the adrenal gland, you can see that this is hypoechoic because of fat, and this is just an adrenal mass. Okay, now basically this is just information on what staging is. So you have something called local regional versus distant. Basically local, if it's basically towards, if it's, for example, in the chest cavity, this is going to be local. If it's more distant, for example, it goes from the lung to the adrenal gland. Okay, that's just an example. And it can spread lymphatic or hematologically. And usually, if it spreads to distant tissues, so for example, lung to adrenal, this is usually stage 4, okay, which is going to be lower survival or higher mortality. And staging will depend very heavily on the type of cancer, because the cancers tend to differ on like what is stage 3, what is stage 2, stuff like that. The differences between the different cancers, you don't need to know absolutely any of that right now. Okay, so PET CT is very much used for that. And the common sites of distant metastasis is bone, brain, lung, and liver. How do you know that this is lung metastasis and not a primary lung cancer? Multiple, perfect. If there's multiple masses, this is clearly a sign of lung of metastasis, okay, to that tissue. So now this patient has lung metastasis, okay? If it's to the brain, it will go to basically to be multiple masses as well, okay? The same thing in the liver. In the liver, in one of the images in the CT part, I showed you guys there's 2 masses. This is pretty much metastasis to the liver. Now for bone, and what do we use for bone nuclear medicine? Very close. I'll give it to you. MDP. Okay. Yes. MDP. Okay. So yes, no worries. So this is just that basically, and showing bone metastasis. And this is the same exact thing as I showed you guys before in the MRI lecture, is basically brain metastasis, and it's a solitary, this one is solitary, what's it called? If it's solitary mostly, it's going to be a primary, but however, you can have it in metastasis, but whatever. In this case, they just want you to know this is a brain cancer, okay, which would be from metastasize. And this is it on T2, and this is one T1 post-gadolinium, and gadolinium is very sensitive to find out basically very small lesions, okay? That's that. And this is the same exact image I was talking about just recently. These are 2 liver masses which are metastasized to the liver from probably the GI system. And this is using contrast because you can see the aorta is bright, and these are the 2 lesions. Any questions on that? Okay. Perfect. Now the very last lecture, which is interventional radiology. This is it's not that complicated. Basically, the whole gist of this lecture, or the whole point of this, is basically now you have a patient who has a certain disease. You can do 2 things at once with interventional radiology. You can both diagnose the patient and treat, both at the same time, okay? Using interventional radiology. That's the whole point of this lecture. And there's specifics of this, okay? Now, the indications to use, what's it called? Interventional radiology is for diagnostic purposes, therapeutic, or pre-surgical. What does this mean? So diagnostic, if you have a patient, for example, who's coming to you for claudication. Claudication, basically, whenever they walk or they do a specific activity, they have pain, okay, in their legs, for example. This is a sign of peripheral arterial disease, okay? Basically, a patient who has a very terrible diet, has diabetes, later on presents you with this. Basically, they have atherosclerosis developing in the peripheral vessels. So anything beyond that point will not be vascularized, will not be perfused. So you'll have peripheral artery disease. which will show us claudication, which is intermittent pain. Because when you're moving, you need more blood supply to that area to supply it. However, you're not getting enough since the lumen is now narrow. So it'll be present as claudication. That's just facts for you guys. Therapeutic, for example, if you have a cyst, you can use a cyst, basically a ultrasound guided drainage. Okay, that's one point of using interventional radiology. Even beyond that, the same patient who had claudication, peripheral artery disease, you can basically use interventional radiology to visualize the vessels and go in and put in a stent, which will keep the artery open. This is part of therapeutic. Versus pre-surgical, where you have, for example, a very vascularized tumor, very, very, very vascularized tumor. You cannot do surgery or else the patient will bleed, okay? So before surgery, you do something called pre-surgical embolization of the tumor, okay? Basically, you inject something that will go, or you'll go through the same thing that you use to visualize a catheter probably. And then you go to that specific lesion and you basically give something to embolize the vessels. Embolization basically means that you're cutting off the supply, okay? And basically when you're doing that, all the supply to that lesion is gone. So now it's no longer highly vascular, meaning that you can now resect the tumor properly with no complications after that or any bleeding. So that's the indications for that. This basically explained like literally 75% of the lecture, just the rest is just pictures. Advantages, it's less invasive, obviously, than just doing surgery. Less pain discomfort compared to surgical intervention, lower overall risk of bleeding, anesthesia, whatever, since it's just basically literally just a hole that you go and then you go into the, for example, femoral artery, and you go from there. It's very simple. It's not like, for example, open surgery. It's lower cost, image guidance help improve accuracy, since everything is under imaging now. Now, types of intervention, non-vascular, you can have diagnostic biopsies. For example, if you have to have a fine needle aspiration of the thyroid, you have to do it ultrasound guided. So you can see where the needle is going, basically. The same thing if you do it on the breast, you have to do it core biopsy, and you do it ultrasound guided. Okay, same exact concept. Therapeutic abscess drainage, as we mentioned, if it has a cyst or an abscess, you do it also the same thing, and pre-surgical localization of lesion. And you have something called radiofrequency ablation. I'll get to where we use that specifically later. Now for vascular, diagnostic peripheral vascular disease, therapeutic uterine fibrosis, chemoembolization, pre-surgical embolization, okay? So now we go through it one by one. For vascular, you have claudication, so you have suspected peripheral, peripheral vascular disease. This is a normal angiogram. Now, what used to happen in just normal angiograms is we just inject the dye into, for example, this patient, we're checking their arm. So this is the brachial artery, this is the radial artery, ulnar artery, medial artery, their arm, okay? And you can clearly tell the whole, vasculature, and everything is normal here. Now, we go a patient with peripheral vascular disease, you want to assess their legs, okay? So now we injected it into, for example, the femoral or the popliteal artery or whatever, or even the radial artery from above, okay, from their upper limb. Usually this one is going to be in the femoral. And then you assess the flow. You can see here, there are thin or like very narrow points in the in this one in the common iliac, okay? So in the common iliac, it's very thin, and it's very thin at the bifurcation point of the aorta, which is right there, very thin. Meaning whenever the patient is walking, the oxygen demand is increased in the legs, they won't be able to supply it. That's why they have claudication, which is pain, okay? So this is abnormal. Now, with interventional radiology, now you diagnose, right? But you can also do something else, which is basically placing a stent, removing the clot, in this case, removing it or dilating it. So you have now interventions that you can do. This is the whole point of that. Next thing is this a symptomatic fibroid. Fibroid, again, this is subserosal fibroid, as we mentioned before. You can treat it by using uterine artery embolization. Basically the same thing, you go through the whole, basically this could be a catheter and whatever the interventional radiologist does, you don't need to know that. Go through the femoral artery, go through the common iliac, and then you go to the area of the fibroid. And you inject basically something that will cause embolization. Okay, whether this is a gel or whatever, medication, whatever, causes embolization. That's the whole point. Basically, you're going to cut off all supply to that fibroid and you're going to treat that fibroid. That's it. The fibroid will die. Why? Because it's going to be necrotic. There's no blood supply to that fibroid anymore. That's the whole point of this. Embolization means that you're going to cut off the blood supply to that mass or lesion, leading to necrosis or death of that tissue. That's how you treat, one of the ways you treat fibroids. And this is just showing you how it looks. Look over here, this is the uterine artery, for example, and you can see it's supplying the fibroid. After you do embolization, you can see that there's no more supply to the fibroid anymore. So this whole fibroid will die, okay? Because there's no more supply to the fibroid. And that's what uterine artery embolization is, okay? Same thing, we can use it pre-surgical. Now with pre-surgical, if it's a very vascularized tumor, you might have to devascularize it a bit by basically doing a embolization. This is an example of a periganglioma, which is basically going to be in the sympathetic trunk. It's a very vascularized tumor. And to be able to resect this tumor, you need to do embolization, okay? And basically you do the same exact thing you did for the uterine fibroid. You cut off the blood supply to the tumor, and then after it, you can clearly tell that it's no longer vascularized, meaning that there's no blood supply there anymore. So now you can easily do surgery with no complication of hemorrhage, okay, because it's vascular. That's one thing you can do. Now, the same thing, that's a basic concept of chemoembolization. Similar exact thing, you might need it for malignant liver lesions with arterial supply. Basically, you do the exact same thing. However, you give basically very targeted chemotherapy that will basically target that lesion in the liver, or the malignant lesion. At the same time, you cut off the blood supply. That's basically all that this is. Okay, it's a very straightforward concept here. Vascular interventions. Was everything clear there? Or do you guys want me to repeat something? Good. Now for palpable breast masses. Now, again, from this exact thing, from this lesion in the ultrasound, what is this? Malignant cancer. Good. What do you do for this? I want you guys to tell me, and I'll tell you if it's right here. If you suspect it's malignant, what do you want to do? Biopsy. Exactly, excellent. Ultrasound guided biopsy. That's basically all you do here. What about this? What do you guys think this is? Okay. It's basically a cyst, okay? Fibroma is correct. Fibroadenoma, sure. It's basically a cyst with some tissue in it. It's a bit echogenic. Again, how do you tell if this is if you really want, again, the concept of cysts, okay? How can you tell if the cyst is benign or malignant cyst? Doppler, thank you very much. That's it, okay? So this one, you do, again, not biopsy, but you basically are going to aspirate the cyst if it's a suspected complex cyst. This is a complex cyst because it's not just anechoic with posterior acoustic enhancement. There's some echogenicity. And when you do Doppler, there's nothing there. Okay, so this is just debris. Okay, so that's basically all that is. So now with this biopsy, you're not really going to biopsy a cyst. Okay, because once you tell that this is a cyst and it's a complex cyst, no need to biopsy it. What you want to do is symptomatic relief for this patient. You basically just drain the cyst. Okay, that's all that this is. You're using the ultrasound to guide your aspiration. Basically, you're draining the cyst. Okay, so that's what this is. If it's a cyst. If it's anything other than cyst, you might do a biopsy. Now, abnormal mammography like this. What is this exactly here? Microcalcification, excellent, good. So microcalcification, do you do a biopsy? Ultrasound first, excellent. What are you looking for in ultrasound? Yep, you're just basically looking for the mass, okay? That's basically it. Once you see microcalcification on mammography, you do ultrasound. That's the next step. On ultrasound, you check if there's calcification. If it's only calcification, versus if there's, for example, a mass. Once you check if there's a mass, then you apply the characteristics of mass that I told you guys before. And then if it's a malignant features of it, you do a biopsy, okay? If it's a microcalcification, no palpable mass, you do something called stereotactic breast biopsy for microcalcification, okay? That's the algorithm for that. Okay, is that clear to you guys? Just remember it as is, because the question will give you if they have microcalcification, ultrasound, whatever, what's the next thing you do? Is stereotactic breast biopsy. Is that clear to you guys? Okay. Now, if you have a patient who you suspect has septic arthritis, which is joint infection, you want to do ultrasound immediately. Ultrasound is the best thing you do. Now, why do you want to do ultrasound? Because septic arthritis, just so you guys know, you do ultrasound for two things. You want to do aspiration. Aspiration is both therapeutic and diagnostic for septic arthritis. The reason is it's an infection of the joint. This is a normal joint. You can clearly tell that the space is, there's no space. Here, there's accumulation of fluid. It's, there's edema building up and so on and so forth. This is signs of a septic arthritis with effusion, okay, which is basically this fluid right here. Once you suspect this, patient has signs of septic arthritis, you want to do an ultrasound, and with the ultrasound, you want to do a guided aspiration. You aspirate the fluid, the swelling will decrease, which will help the patient, or the fluid, the pain will decrease. Second thing is you need to aspirate the fluid to send it to lab for diagnosis of septic arthritis. That's why it's both diagnostic and therapeutic. So here you can see the needle going in and aspirating the fluid. Okay, so suspected joint infection, what's the modality of choice? Ultrasound, and you do ultrasound guided biopsy. Good. Lung lesion. What do you guys think this lung lesion is? Is this mostly benign or has malignant features? For joints, yes. If you're suspecting, for example, just to answer your question, for joints, if it's not septic arthritis, if you're suspecting, for example, ligament tear, as I mentioned before, and you're trying to assess soft tissue, it's MRI. If you're suspecting bone fractures, X-ray. Okay, that's it. So this, for example, what do you guys think this mass is? Is this most likely malignant or benign? Malignant. The reason is the borders. You can tell the borders are just very irregular and so on and so forth. Like it's just all over the place. And this is long window. If it's a very like circular tumor or mass, it might not be malignant. But these are signs of malignancies. Like if it's very like ill-defined borders and so on and so forth. Here you do biopsy. How do you do biopsy of this? Not ultrasound guided. It's CT. Okay. Why is it not ultrasound guided? Is this? What's an enemy of ultrasound? Bone and air. Once you have bone, okay, which is the vertebra, I mean, not the vertebra, the rib cage, you won't be able to check, like see anything beyond that point because it's very, very, like hyperechoic. It will be just, you won't see anything beyond that point. Okay. Because of this. And another point is air. Air because it's the lungs. Okay. So lungs are filled with air. You won't be able to see anything at all. So you do CT guided. Okay. Lung biopsy, not ultrasound. Is this clear? Good. Now, just as this, now you're treating the patient. The patient had a tumor somewhere that metastasized to the lung. Now you're trying to remove the lung lesions. If it's very large palpable mass, you can just remove it surgically. If not, you have to do something called coil localization. The exact reason or what this is, I am not too fully sure about. I'm very sorry about that. But just know, small non-palpable lesions form a metastatectomy. You do coil localization. Okay? That's basically the concept here. If it's very large, palpable, you just remove it, surgical resection. You can visualize it very clearly. If it's very small lesions that are non-palpable, then you do core localization. Okay, now this. An elderly patient with obstructive renal stones and worsening renal function. Okay, what is the modality of choice here? Ultrasound, good. So the reason why this is ultrasound, because it's worsening renal function, something that's repetitive, chronic, and stuff like that with obstructive renal stones. It's not acute, exactly. Excellent. So on here, you see hydronephrosis. What do you do here in this case? Lithotripsy is basically you're sending frequencies to destroy the stones from outside. That's what lithotripsy is. Surgical resection, it's very invasive. Why would you do this? Here now, for this patient, the acute presentation of this patient is hydronephrosis, not the stone. Okay, so you're trying to relieve the patient from hydronephrosis, and this will improve the renal function. So with this, you do percutaneous drainage. The percutaneous drainage is basically you're going from outside to inside, and you're going through the kidneys, and you're basically going to drain it from the calyces. Why would you not go from the ureters? Just for your concept. This is ultrasound guided. This one isn't. I'm not too sure what this is actually, but it's not ultrasound guided. I'm pretty sure this is. I'm not too sure, but it probably is. Yes, you're probably right. It usually is ultrasound because you can see like the what's it called, the drainage here, and you can literally see the needle going in from here. But yeah, this is a percutaneous nephrostomy. You can just go in and remove it. The reason why it's not going from the ureter is because the guy had multiple stones. Can he really go through the ureter? No. Okay, that's just basically why you're going percutaneous. You're trying to relieve the patient. No. Okay. Now for the thyroid, you have this. Is this a cyst or a mass, a malignant mass, or a tumor? A nodule, a mass. Good. It's not a cyst. So for cyst, now you need to do a biopsy. The way you do a biopsy is going to be a percutaneous fine needle aspiration, ultrasound guided. That's it. You can see the needle here, and it's basically FNA. FNA is the way you check for thyroid. Core is for breast. Okay. If by any rare chance they ask you that, now you know. Okay. But I doubt they're going to ask you that. FNA is for thyroid. Core biopsy is for breast. Okay. Just as a fun fact. But yeah, that's basically what you do for thyroid masses. You do next step once you see that it's a nodule. You want to biopsy a nodule, you do it by percutaneous for fine needle aspiration, ultrasound guided. Okay, that's it. Renal mass. Now, is this a cyst or a malignant mass? Good. What would you do for this patient? For this one, I mean, this is a CT. But what I would like, the reason why you go straight to ablation in this case is these features is very specific for a tumor. Okay. Okay, it's very, 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 very specific for a tumor. Okay, a specific type of cancer. Plus, the patient will show signs of cancer. You want to treat this patient. One of the ways you can treat it is radiofrequency ablation, which is basically this. You are specifically targeting the mass by radiofrequency, and you're basically ablating the mass. So you can go from here. This is the tumor before you do the ablation. This is the tumor during the ablation. You can see it here. And then this is basically the tumor afterwards. It's basically exactly. This is what's it called? Laser knife radiation. Okay, which is basically a very targeted radiation towards the tumor. Very targeted radiation. Okay, and this is before, after, during, after. Okay. Thank you, guys. Do you guys have any questions before we go to practice questions? Any questions at all? Was everything clear to you guys? Yeah, I threw some fun facts there, just like in case you guys get a clinical scenario, now you know what the thing presents as. Okay, so now I'm gonna do questions. So now here, 35-year-old female underwent ventilation perfusion. One second, guys. Okay, a 35-year-old female underwent ventilation perfusion scan. Image provided. Which of the following is most appropriate? Image B is acquired using inhaled radioactive gas. The diagnosis is pneumothorax. Image A uses phosphate or biphosphate carrier. Image B demonstrates perfusion defects. Which one is the answer? Okay, the correct answer is D. Okay, why? This one, image B, you can see a perfusion defect. Okay, this is a perfusion defect right here. This is normal ventilation. You can see clearly everything is well ventilated. This is the left lung. Okay, the reason why this part is not ventilated is because the heart is there. Okay, just from the anatomy. And this is the rest of the lung. Okay, now this is the perfusion defect. So this is a VQ mismatch. Inhaled radioactive gas is used for this. What do we use for image B? Exactly, technetium albumin, radiolabeled albumin. Kn is the gas. Okay. Diagnosis is not pneumothorax, and it does not use phosphates or bisphosphates carrier. Next question. Which of the following is most appropriate regarding use of radiology in investigations for pregnancy? A, MRI is not safe. Ultrasound is preferred over CT. General X-ray is contraindicated. Or MRI is preferred over ultrasound. Exactly. Now look, you're going to get these questions in some form. Most appropriate, okay? Like, it might not be contraindicated in everything. You know, if it's last resort, something you need to do, if everything else isn't, you might need it, okay? So that's just, you know, the wording that they might use in your exams, unfortunately. MRI is safe. It does not use radiation. Ultrasound is always preferred over CT in pregnancy. MRI is not preferred over ultrasound because ultrasound is a quick MRI. You're going to need to wait 40 minutes. And basically the stuff that you can localize exactly is also cheap. Ultrasound is very cheap. MRI is not. And the things that you need to localize would be more apparent in ultrasound because it's more acute conditions and you need something very fast and so on. So you need to use ultrasound. Now here, which of the following is true regarding the diagnosis of nephrolithiasis, which is stones, kidney stones? Diagnosis cannot be made on ultrasound. MRI imaging is most appropriate initial imaging modality. General X-ray is appropriate in children. CT is an appropriate imaging modality. Okay, I got one D and everyone said, sorry, a multiple D. Everyone said D except one. Now, the answer is D. A, it can be made on ultrasound if it's in the kidneys. It can. It cannot, like, it's not absolutely not. If the stone is in the kidney, it can be diagnosed by ultrasound. First modality, most sensitive, most appropriate is CT. Okay. So now I'm done with my questions. I'm going to have a surprise cameo by Tariq, who will have the next questions.
No. Okay, so which of the following is most appropriate for MRI? Is it A, that it can differentiate fat from blood? Oh, you're going to draw? Okay, fine. Is it B? Okay, decide. Which one of us will draw? We can't keep going back and forth.
I'm going to draw.
Okay, fine. So is it or B, first imaging modality for acute appendicitis? C, gadolinium increases attenuation on MRI? Or is it D, useful for assessing patients with polytrauma? Okay, so I'm seeing quite a few C's, but the answer for this one's actually A, right? And so the reason is that, so the thing about C is that gadolinium might appear very bright on MRI, but it's not going to increase attenuation. Because remember, MRI doesn't use attenuation in the first place. When we talk about attenuation, we're usually talking about something like ultrasound or CT scans, right? Whereas with A, like we mentioned yesterday, the reason MRI can differentiate fat from blood is because blood is a fluid and because it contains hemoglobin, right? So so when you shoot the magnetic field through the fat and the blood, it's going to cause the shift from the hydrogen protons. And then the relaxation time from fat compared to blood is very different. And so because of that, on both T1 and T2, they're going to look very differently. Is that clear? All right. So next question. What is true about iodinated contrast? Is it A, appears hypoechoic on ultrasound? B, contraindicated in patients? C, has a high attenuation? Or is it D, appears hyperintense in T1 MRI? All right. So I'm seeing a lot of C's, and yeah, that's the right answer. So again, the reason iodine has a high attenuation on CT is because it's a very dense material. So when you inject it into the patient's blood vessels, it's going to appear very brightly as it travels through. And that's why we would like to use it for stuff like aortic dissection. Okay, next question. A bit of a long one. So in relation to the classification of deterministic and stochastic effects, which one doesn't have a radiation dose threshold related to its occurrence, and its probability, but not severity, increases with the radiation dose? Is it A, skin damage, bone damage, leukemia, or infertility? This one's a bit of a confusing question, so I'll give you guys a second to think about it. Okay, so for this one, the answer is C. And the reason is C is that when you look at the different effects that happen with the different radiation doses, what you'll notice is that there are some things which are deterministic, where it's like the moment you give the dose, it's going to hit a threshold and then you're going to start seeing damage. Whilst there are others where it doesn't necessarily directly cause the damage, it just increases the probability that you'll see it, right? And so for stuff like skin damage, bone damage, and infertility, you know for a fact that when you're exposing the patient to the radiation, this is going to happen, right? And like after a certain threshold, you're going to see skin damage, you're going to see bone damage, and you're going to start seeing some signs of infertility. And the more you increase the dose, the more severe it's going to get. All right? Whereas with leukemia, you're not going to see the same relationship. What you're going to see is that after you give the patient more radiation, they're more likely to get leukemia, but it's not related to how severe it is, and it's not related, and there's no like specific threshold you're looking at. Was that clear? All right. And I think that's all from me.
All right, guys. Thank you guys so much. Inshallah, the exam is easy. Cover the points that we both mentioned in both of the PAL sessions, inshallah. It just comes from that, and it's very simple questions, inshallah.
Before we close up, do any of you guys have any questions related to anything at all in radiology?
All right, guys.
Yeah.
Best of luck, inshallah, in your exam.
Best of luck. Inshallah, you guys will do great.